See, it said Piedmont Symposium. See, that's what before it's just Piedmont.
This is specific to.
Yes. So this will allow screen sharing. So we shouldn't be able to do this now. We're just going to go to that one. Then it's going to take us to there. We're going to here. I'm also going to recording. Should be able to go now. Okay, thank you. Take it away.
Hi, my name's Avery Spartlin. My presentation is about the impact of breastfeeding on childhood obesity. Okay. So so this is my research question. Do infants who are exclusively breastfed for the first 6 months of life have a lower risk of developing childhood obesity compared to infants exposed to other sources of nutrition in the first 6 months of their lives? So just to clarify my question a little more, so the population we're looking at is infants who are only breastfed for the first 6 months of life. The intervention that we're looking at is breast milk as the only source of nutrition in the first 6 months of life. And the comparison group is infants who are given formula or given other sources of nutrition in the first 6 months of their life. And then the outcome in question is, does the intervention lower the risk of obesity? So a little background on this topic. The prevalence of obesity in children has increased dramatically during the past few decades, not only in developed countries, but also in developing countries. So a recent study stated that the prevalence of childhood overweight and obesity has increased by 47.1% between the years of 1980 and 2013 worldwide. So childhood obesity is a significant risk factor for adult obesity and other negative health consequences such as type 2 diabetes and heart disease. So one specific protective factor against obesity is breastfeeding in early childhood. So the World Health Organization and the American Academy of Pediatrics both recommend exclusive breastfeeding as the only form of nutrition for a baby in its first 6 months of life. So I looked at 5 articles for my research paper, and the first article was titled Infant Feeding and Weight Gain, Separating Breast Milk from Breastfeeding and Formula from Food. And this was a cohort study done in 2018. And the purpose of this article was they were investigating the correlation between breastfeeding and childhood obesity, including specific factors such as feeding methods, type of supplementation, and feeding in the hospital. And so the population in this research article was 2,553 mother-infant pairs that were a part of the Canadian Health Infant Longitudinal Development Birth Cohort between the years of 2009 and 2011. So the results of this study showed that infants who achieved the World Health Organization recommendation of 6 months of only breastfeeding had a mean BMI Z-score that was lower than infants who are not breastfed for at least 6 months. And the mean BMI Z-score is just a normal BMI that also accounts for the child's age and gender. And so just because it's important to look at our limitations and strengths of research, one limitation I want to point out from this article was that it contained a limited amount of data on mothers that never breastfed their babies. And then a strength of this article was that it used multiple statistical approaches to consider all potential factors such as socio-demographic, ethnicity of the mom, and education levels. So the second article I used was titled Breastfeeding and Childhood Obesity, a 12-country study. So this was a multinational cross-sectional study from 2020. And the purpose of this article was to examine the association between breastfeeding and childhood obesity after adjusting for numerous variables such as maternal BMI, gestational age, and the child's birth weight. The population in this study consisted of 4,740 children, and it was split pretty evenly between boys and girls. And the children were from 12 different countries with various demographics. So the results from this study showed that after an adjustment for maternal age of delivery, maternal education level, history of gestational diabetes, gestational age, the child's sex and birth weight, unhealthy diet pattern scores, and sleeping times, the odds ratio of the childhood general obesity was significantly lower among children with exclusive breastfeeding compared to children that received exclusive formula feeding. And so a limitation of this article was that the study was a retrospective study, meaning it was based off self-reporting data from the moms, which can lead to inaccuracy in the data. And then a strength of this article was that it had a globally diverse sample from 12 different countries and various economic levels. So the third article that I used was called Full Breastfeeding and Obesity in Children, a prospective study from birth to 6 years. So this was a longitudinal prospective cohort study, and the purpose of this article was to investigate the effective duration of breastfeeding on excessive weight and obesity at 6 years of age. So this was a pretty cool study because it followed the children from birth to when they were 6 years old. And the results of this study showed a reduction of 3.5% of BMI in 6-year-old children by each week increase of FBF, and that's just a term they use it means full breastfeeding, which means they only receive breast milk during that duration. So, and then limitation from Article 3 was that the study's population was limited because it was only 350 mother-infant pairs. And a strength of this article was that it was a longitudinal study, like I said, in which allowed the researchers more time to account and observe for confounding variables. So the fourth article I used was titled The Association Between Breastfeeding and Childhood Obesity, a Meta-Analysis. So this study was a meta-analysis, and the purpose of this study was to investigate the association between breastfeeding and the risk of childhood obesity. So the results of this study showed through a categorical analysis of 17 different studies that a dose response effect between breastfeeding duration and the reduced risk of childhood obesity. So more specifically, breastfeeding was associated with a significantly reduced risk of obesity in children. And so a limitation from Article 4 was that the BMI cutoffs used to define obesity in all the studies were different in some compared to others, which might have impacted overall estimates. And then a strength of this research article was that it was based on adjusted odds ratio and a 95% confidence interval, which greatly rules out residual factors in the data. So the fifth article I used was titled, Does Breastfeeding Lower the Risk for Childhood Obesity? What is the evidence? So the purpose of this article was to determine whether breastfeeding was protective against childhood obesity, very similar to all the other articles. And the population was 226,508 infants that were either breastfed exclusively for the first 6 months of life, given only formula, or they were infants that received a combination of formula and breast milk. So the results of this study showed that if a child was breastfed for 7 months or longer, then that child was significantly less likely to be obese. So additionally, the researchers concluded that the risk of childhood obesity was 22% lower in breastfed children than the children that had never been breastfed. So a limitation from this article was the potential for the potential research bias in the selection of research studies that they chose to include in the meta-analysis. So obviously the researchers are going to choose research articles that are supporting what they're researching. So a strength of this article was the very large sample size, because the large sample size increases the reliability of their evidence. So looking at just the literature overall, some themes that I saw was that the longer a child is breastfed exclusively, the more health benefits the child receives from breastfeeding. So infants who are exclusively receiving breast milk for the first 6 months of their life had a healthier composition of gut microbiome and positive feeding behaviors. And these two specific factors, the composition of gut microbiome and the positive feeding, these were two specific things that directly lowered their risk of childhood obesity. So another theme I saw was the significance of other factors besides breastfeeding that might impact a child's risk for obesity. So these were things such as maternal BMI, maternal education level, the socioeconomic status of the family, sleeping patterns, and additional factors. So just for an example, like with the education level, so if a mom had a lower education level, she might not have the knowledge and awareness to know how good breast milk is for her baby. So that could definitely influence her choices. And then for the socioeconomic status of the family, if a family has a lower socioeconomic status, they might not have the financial resources a mom needs to like say she wants to breastfeed her baby, but she's having issues with the baby latching. They might not have the financial resources to go to an OB or a primary care provider to help with those issues. So you have to think about factors like that. And then another theme that I noticed throughout the literature was response bias. So a number of these studies received data from self-reporting information from mothers, which increases the risk for response bias greatly. So if you think about it, a mom that is breastfeeding her baby is more likely to join a study that is about how good breastfeeding is for her baby. So you have to take into consideration factors like that. So the studies had to discuss how they accounted for the response bias in their results. So how does this topic relate to nursing? So nurses have an important role in encouraging and supporting breastfeeding. The nurse interacts with expecting mothers on many occasions during pre- and postnatal appointments, and the labor and delivery nurse is there while the mom is giving birth. And so these interactions are opportunities to advocate for breastfeeding through teaching and education. So one specific role that in the nursing field that could utilize this information is a registered nurse that practices as a lactation consultant. So by utilizing the evidence and the information through in this literature, the lactation consultant and any nurse in the field can provide extensive data and support for why breast milk is the most beneficial nutrition for a baby in its first 6 months of life. Those are my references. Does anyone have a question? Awesome.
Okay. Let's get out of this slideshow. It's different. Get out of this. Bring up the next PowerPoint slide. Sarah, you're next. You're batting next.
Okay. Click the one that's black.
And share. Good. Thank you. Sarah Sudduth. Sudduth, sorry.
No, it's okay.
Sudduth, next.
Ready?
Okay.
Okay. Hi, for those of you who don't know me, my name's Sarah Sudduth, and I'm a graduating nursing student. I currently work at Children's Healthcare of Atlanta and have accepted a job there post-grad as a nurse. So I decided to do my capstone on the use of toy-mediated distraction as an effective pain management tool in toddler vaccination. So why did I choose this topic? It's pretty common for kids to be scared to get shots. I know when I was little, no less than 5 medical assistants would have to hold me down during my annual doctor's appointment. And this childhood fear often transitions into a lifelong fear of needles. This becomes an issue when people begin to avoid their adulthood vaccinations, like updating their tetanus, getting the annual flu vaccine, and the recent COVID-19 vaccinations. As a nurse, I feel that it is my ethical responsibility to utilize scientific evidence to find methods of distraction that can avoid this anxiety and fear associated with vaccines, thus improving vaccine recommendation compliance. Okay. In recent years, the use of a distraction technique during vaccination has gained a ton of popularity. However, most of the studies that I used for my research proved to be equivocal, meaning that there wasn't a clear causal relationship between the intervention and the outcome. Additionally, many of the articles that I found utilize various methodologies in conducting their research, which you'll see when I present my findings. For this topic, I developed a Pico question, which is a mnemonic that stands for population, intervention, comparison, and outcome. This is the format used in healthcare clinical research to build our research question. The question that I developed was, is using toys as a distraction during needle vaccination of toddlers effective in pain response management? So my population was toddlers. My distraction was toy distraction during vaccination. The comparison was no intervention, so no toy distraction. And then the outcome was lower pain response. On the next slide, I had a video, we don't have to watch it, but it was just kids talking about how toy distraction really did help during their vaccination. So I found 6 scholarly peer-reviewed articles on either Galileo or Google Scholar. The main keywords I used on the search engines were vaccination, toy distraction, and toddler. Those were the words that I absolutely had to have in the articles that I reviewed. Additionally, the articles needed to be within the last 10 years. And since we did this research last semester, it was 2011 to 2021. The 6 articles that I ended up using all included the evidence type, sample size, setting, findings to answer my Pico question, observable measures, and strengths and limitations. My first article, titled Toy-Mediated Distraction, Clarifying the Role of Distraction Agent and Prenatal Distress in Toddlers, was a randomized controlled trial at a pediatric clinic in Toronto. For this trial, 99 toddlers were assigned to one of 3 distraction groups. The first being parent distracted, the second being research assistant directed, and the final one being no distraction. To clearly show the role of the independent variable, being toy distraction, this study controlled all aspects of the experiment. And by that, I mean, they took into account the factors of timing, of exposure, length of distraction, toddler position during the procedure, and naturally occurring soothing behaviors by the parent. They also separated the toddlers into groups based on how much baseline anxiety they had. Unfortunately for this trial, the results were inconclusive. For the parent distracted group, the toddlers were already in distress, so it didn't help at all. The toy distraction had no effect on the overall distress score. And the toddlers viewed all interactions with medical personnel as stressful, which is pretty common in toddlers. Though this study was inconclusive, I still chose to use it as my research because it was the first ever study done to test distraction effectiveness. The final conclusive note made by this group was the suggestion that in future studies, the distraction needs to be implemented prior to any onset of nerves. The second study that I looked at assigned 350 random toddlers to one of 3 distractions. This study actually tested different distractions against one another. So the first group received a distraction via light and sound producing toy, like those little toy pianos where the keys light up when you press them. The second group was distracted by cartoon movies, and the final group received no distraction. The researchers in this trial used the FLAC pain scale, which assesses facial expression, leg positioning, activity level, crying, and consolability to measure pain in children ranging from 2 months to 10 years old. The results of this study found that light and sound producing toys are most successful in distracting toddlers. Additionally, the large sample size in this trial enhances the validity of the results. This result affirms my Pico in that it shows toy reducing vaccination pain in toddlers. The next research article that I used was a bit different in that it was a systematic review of various randomized and quasi-randomized controlled experimental trials. This systematic review looked into 10 studies and the results to see how effective the distraction technique was, as well as the amount of bias present in the study. It found a negative correlation between toy distraction and pain response, meaning that distraction proved to lessen the pain response. So this study supported my original thinking in toy distraction being an effective tool in reducing pain in toddlers. For my fourth article, I reviewed an experimental study that assessed how distraction affected pain response during toddler vaccination. In this study, 116 toddlers at a children's hospital in Pittsburgh were chosen randomly to be in one of 3 groups: toy distraction, music distraction, and no distraction. Again, the FLAC scale was used, and the study found that toy distraction was the most effective technique in reducing the stress response in toddlers. A quasi-experimental study was used in my 5th article to add to the existing literature, an attempt to show that pain reduction techniques should be the standard of care during toddler vaccination. In this study, 100 preschool-age children received either a therapeutic toy, video game, role play, comfortable position, wrist water toy, or no distraction. This study utilized 2 different methods to measure pain, anxiety response in these children. The first of which is FACES, which is that 0 to 10 chart with different levels of pain emotion being expressed on the faces, which you've probably seen at the doctor's office. The second method is what's called CHEOPS. I've always called it CHEOPS, I don't know. But it's very similar to FLAC in that it looks at the body language to determine amount of pain. This study showed toddler distraction to be the most effective method in reducing anxiety. My final article presented an experimental multi-intervention post-test control design to compare the effectiveness of various distraction techniques. In this trial, 100 infants were randomly selected and put into one of 4 groups: electronic toy, key toy, simple toy, and control, which had no toy. The result of this study showed the control group to have the highest pain response and electronic toys to have the lowest pain response. To add to the validity of this study, the CAPA method, which measures statistical reliability, calculated a 0.83 reliability, which is a high validity. This proves toys to be a helpful tool in pain response management. 5 out of the 6 sources found toy distraction to be an extremely effective method in pain management. And the only one that didn't find it effective was the landmark study that showed that the intervention needed to be put into place prior to the initial vaccination nerves. In conclusion, a significant amount of toddlers had lower pain response when the toy was put into place, proving that this should be the standard of care. I'm gonna read this.
Is this working? Really? Oh, screen stopped. All right, well, I'll pull up another one. Thank you. Sydney.
You press the space bar to advance.
Probably. We'll try it before.
Figure it out.
I just gotta get the, it's on recording. Make sure screen share is up. And that's you, right? That's your.
Yeah.
We've been using this to advance, but now it doesn't. It's working. Okay.
Okay. So just like click on it.
Oh, spacebar does work.
Oh, thank you.
Okay. So Sydney Greer? Greer.
Yes.
Sydney Greer.
Okay, so hi, my name is Sydney, and today I will be presenting the effects of COVID-19 vaccinations on outcomes in pregnant women. So I apologize in advance because I know we are all so sick and tired of COVID and hearing about COVID, but it has had a substantial impact on the world as we knew it. In December 2019, the first coronavirus case was reported in Wuhan, China. This quickly spread to the United States, and on March 11th, 2020, the World Health Organization designated the outbreak a pandemic, which is a disease that affects a whole country or the entire world. Vaccines were approved for emergency use in December 2020, but it left the ultimate question of, how does this protect vulnerable populations like pregnant women? According to the American College of Obstetrics and Gynecology, the data in 2021 revealed that pregnant women have a heightened risk of severe complications and even death when infected with COVID. The CDC stated that only 31% of pregnant women had been vaccinated against COVID, and that there were more than 125,000 confirmed cases in pregnant people through September 27, 2021. Of these cases, more than 22,000 were hospitalized and 161 died. Data following this indicated that over 95% of those hospitalized or dying from COVID remained unvaccinated, and that those waiting until after delivery to obtain vaccination status are potentially exposing themselves to increased risks of severe illness or even death. So the bottom line being that pregnant women are at this increased risk, but what have the recommendations been? Of course, as I'm sure we all do in our sleep by now, social distancing, wearing a mask when within 6 feet of others, and practicing proper hand washing. An article from the Journal of Transcultural Nursing stated that the most effective method against COVID is primary prevention, which includes preventing disease occurrence through immunizations. So with pregnant women being a specific population at risk and preventing disease occurrence through vaccination being the recommendation, the purpose of this review is to determine if outcomes were improved in pregnant women who received the COVID vaccination. An article from the Canadian Medical Association Journal sought out to evaluate the association between COVID infection during pregnancy and adverse pregnancy outcomes. A systematic review and meta-analysis included 438,548 women who were pregnant. And pregnant women infected with COVID was associated with preeclampsia, preterm birth, stillbirth, and NICU admission when compared with no COVID infection. And these risks are associated with particularly problematic adverse maternal, fetal, and neonatal outcomes. So this article was to determine the vaccine's effect or potentially lack thereof on pregnant women. So research was done first on pregnant women without a COVID vaccination to allow a comparison of outcomes in pregnant women who did receive the vaccination. This article in particular recognized the lack of good quality data in the early stages of the pandemic that was needed to draw unbiased conclusions. Since clear evidence was provided that symptomatic or severe COVID is associated with a considerable risk of preeclampsia and preterm birth, it contrasted previous reviews that stated otherwise. So another study from the Journal of the American Medical Association sought to evaluate the immunogenicity or the ability to provoke an immune response of COVID mRNA vaccines in 103 women. 30 were pregnant, 16 were lactating, and 57 were not pregnant or lactating. The study also included 22 pregnant and 6 non-pregnant unvaccinated women with a COVID infection. So the COVID vaccination was immunogenic, so able to provoke an immune response in pregnant women. And in fact, the vaccination elicited higher antibody responses than natural infection did, in which this response was transferred to the infant. And this response included, or the antibody response included against variants of concern. So ones we've seen or heard of recently are like Delta and Omicron. So COVID vaccinations were immunogenic in pregnant, lactating, and non-pregnant, non-lactating individuals. This study also validated similar prior studies that stated that vaccination elicits higher antibody responses than natural infection. This study also suggested that maternal vaccination in pregnancy may confer similar benefits for newborns who may be ineligible for vaccination. Another article from the Journal of Clinical Investigation investigated the effect of the vaccine compared to native infection on maternal and fetal responses on a total of 1,094 pregnant women who were further stratified into 3 different groups. 105 received the vaccine, 94 were unvaccinated with past positive PCR results, and 895 were unvaccinated without prior documentation for infection. This study proved that COVID vaccination induces robust maternal humoral responses that transfer to the fetus, and that antenatal immunization will potentially provide adequate maternal and neonatal protection at highly vulnerable life stages. An article from the American College of Obstetricians and Gynecologists sought to evaluate the frequency of placental lesions commonly seen in maternal COVID infection in patients who received the COVID vaccination during pregnancy. A total of 200 women were included in this study, and they were further divided into 2 groups. 84 had received a COVID vaccination during pregnancy, and 116 did not. So women who were vaccinated were more likely to deliver vaginally and showed robust antibody responses, similar to previous studies done, when compared to the control group of unvaccinated women. The cohort of vaccinated women did not have an increased incidence of placental abnormalities, which included decidual arteriopathy, fetal vascular malperfusion, low-grade chronic biliitis or chronic histocytic interbiliositis. And the incidence of high-grade chronic biliitis was higher in the control group composed of unvaccinated women. So this article concluded that a higher incidence of placental abnormalities was present in the unvaccinated group, therefore improving maternal and neonatal outcomes in women who received the COVID vaccination. A study from the Vaccine Journal compared the short-term outcomes in vaccinated and non-vaccinated pregnant women. A total of 432 answered the first questionnaire, of which 326 responses were received to the second. So results revealed that mRNA vaccination during pregnancy did not appear to increase the rate of pregnancy complications and is an effective measure in COVID prevention. This study was actually one of the first series that addressed the short-term outcomes of vaccination. Of the 124 women in the unvaccinated group, the main reason for avoiding vaccination was lack of information regarding its safety in pregnancy. So the authors recommended that further studies addressing short and long-term complications are crucial to provide the physicians and the patients with knowledge against COVID during pregnancy. Since the rate of complications failed to increase in those who obtained vaccination, this study demonstrated that COVID vaccination does not have a role in composite pregnancy complications. The vaccine also reduced the risk for COVID infection from 6.5% to 1.5%, thus improving outcomes through subsequent avoidance of disease occurrence. Since pregnancy outcomes inevitably include that of the fetus or neonate also, the CDC's Morbidity and Mortality Weekly Report assessed the effectiveness of maternal completion of a 2-dose primary mRNA COVID vaccination series during pregnancy against COVID hospitalizations in infants. Among 379 hospitalized infants less than 6 months of age were included in this study. 176 had COVID and 203 did not. Of the hospitalized case infants with COVID,
84% were born to mothers who were not vaccinated. 43 were admitted to an ICU, and of the 43 admitted, 88% had mothers who were not vaccinated. The mothers of the one case infant who required ECMO and the one case infant who died were both unvaccinated. But what about the mothers who were vaccinated? So in this chart here, you can see that vaccine effectiveness was actually higher when women were vaccinated later in pregnancy, being 21 weeks gestation up until 14 days before delivery, when compared to vaccine effectiveness only being 32% when women were vaccinated earlier in pregnancy, so within the first 20 weeks. Since this study was conducted from July 2021 through January 2022, when the Delta and Omicron variants were actually predominant, it validates previous research that states that vaccine provides protection against emerging variants of concern. The author's findings of a higher vaccine effectiveness when vaccinated later in pregnancy guides further studies for optimal times of maternal vaccination. So the CDC currently recommends that women who are pregnant, breastfeeding, trying to get pregnant, or might become pregnant in the future, get vaccinated and stay up to date with COVID vaccination. So currently, the CDC is conducting a V-Safe program that's intended to monitor pregnant women who receive a COVID vaccination to ensure that their reported clinical data aligns with the growing body of evidence about the safety and effectiveness of COVID vaccination during pregnancy. As of March 28, 2022, more than 202,000 V-Safe participants have indicated that they were pregnant at the time of COVID vaccination. As the CDC gathers this data, it can be viewed by the public and published reports online. It's been stated that pregnant women are a notable at-risk population in regards to COVID infection, and that the suggestion is to avoid disease occurrence through obtaining vaccination. But with the lack of vaccine trials performed on pregnant women, how can healthcare professionals expect mothers to make such a decision? So the CDC plans to use this information being collected in the V-Safe program to educate the public and guide recommendations on COVID vaccination during pregnancy. Names, identifying information, and personal data is not included in these reports, but allows current and future pregnant women to be involved in and have access to information crucial to decisions regarding COVID vaccination. That's all.
I don't know if this is part of the study or anything in articles, but the efficacy of 2-dose mRNA versus the 1-dose Johnson & Johnson.
A lot of the studies didn't do research on the Johnson & Johnson one. I think it might have been because like the controversy with all of it, but that one study that was done recently just did 2 doses. And there were some that included just 1 dose compared to 2. And of course, the effectiveness was higher when 2 doses were completed. Any more questions?
Let's get out of it. Okay, screen sharing. It was on. It's closed. It's stopped now. So.
Yeah.
Is that why the static is going? Because I grab the screen and it shares. This is weird. We have a lot of static.
I would close these other ones.
Oh, PowerPoints.
Where's your static?
In-house in the room.
That way you know which one's open. This one's gotta be.
Okay.
Because you couldn't see her.
Oh.
It was just showing.
Oh, damn it.
Started. Now they're on the screen. Minimize it, do screen share. When it's black. That would be the. Should be good.
Yes. So
Just to make sure it gets through.
she can't see herself. That's the problem.
Oh, it's okay. I don't want to see myself.
Okay, that's fine.
Anslee?
And I use this,
You can use. Yeah, try. Maybe not.
so I need to use this.
These will work. The spacebar works too.
With the space button.
We're not.
Nope. Perfect. So I just need to click.
Yeah, so say now you're on it.
So this is working now. Okay.
Anslee Webb?
Okay, I'm ready. Good afternoon. My name is Anslee Webb, and I'm a senior nursing student at Piedmont University. Today, we are going to go beyond the physical and discuss the psychosocial effects of COVID-19 on school-age children. COVID-19 is a new issue plaguing our society. This virus is caused by SARS-CoV-2 and attacks the respiratory and gastrointestinal systems. Mortality rate is highest in those with pre-existing conditions. In attempts to stop the spread of the virus, 1.4 billion children lost access to daycares, playgrounds, team sports, and schools in a short amount of time. For the healthcare system to be properly prepared for a possible influx of psychiatric patients, we need to evaluate the implications of COVID-19 has had on the psychosocial effects of children. In order to do this, I came up with the Pico question. In school-age children, does the COVID-19 pandemic adversely influence psychosocial health compared to pre-pandemic conditions? 6 scholarly peer-reviewed articles were searched for using the keywords pandemic, children, and psychosocial. These articles were obtained online from the Piedmont University's library search engine, Galileo. Perceptions, emotional reactions, and needs of adolescent psychiatric inpatients during the COVID-19 pandemic. The purpose of the first article was to investigate through interviews the perceptions, emotional reactions, and needs of psychiatric patients ages 12 to 17. The interviews took place in April of 2020 and included inpatients of a psychiatric intensive care unit located in Athens, Greece. Negative feelings were acknowledged in the interviews about COVID-19 included restrictions on personal freedom, excessive contact with family members, mood swings, anxiety, thoughts of self-harm, and harming others. The limitations of the study is that there were only a small number of participants. The strength is that the interviews were able to reveal information about school-age children's thoughts and perceptions of COVID-19. Potential psychosocial impact of COVID-19 on children. The aim of the second article was to try and understand the potential impact of COVID-19 on children's mental health, nutrition, academic performance, recreational habits, and family wellness by drawing parallels to past pandemics and epidemics. The scoping review was completed using the 5-stage Artskis and O'Malley methodology. 8,332 articles were screened for eligibility. 73 articles were chosen because they included children ages 0 to 18, a prior or current pandemic or epidemic, and child or family-related outcomes. The research in this article is important because it allows us to see that there is a positive correlation between pandemics and the psychosocial health of children. The limitations of the study is that it only included material written in English. The strength of the study is that it can be used as a starting point to create programs and solutions from the challenges children face during pandemics, including the COVID-19 pandemic. Psychosocial impact of COVID-19 lockdowns in school-age children and adolescents and Caracol. The goal of Article 3 was to determine if there are behavioral changes in children living under lockdowns, and if so, to identify why these changes are taking place. 238 families were given a strength and difficulty questionnaire, which is a behavioral screening, on the first day of lockdowns in March of 2020. They were giving this same screening again 1 month later. The total scores of the initial assessment and follow-ups were then assessed. The results of this study showed that 1 month after lockdowns, there was an escalation in parental conflicts, emotional problems, peer relationships, and hyperactivity issues. The limitations of the study were the small sample size. The strength of the study is that it was conducted from day 1 of lockdowns in the community setting. Children and coping during COVID-19. The purpose of the fourth article was to provide insight regarding the impact of COVID-19 outbreak on children's mental and physical health. In this article, a scoping review was performed to answer the question, what are the challenges for children's mental health, emotional health, and physical well-being during COVID-19? For the research, a multinational team assessed the literature and created a synthesis based on the review. The articles found that among 320 children ages 3 to 18, the most common psychosocial issues were clinginess, distraction, irritability, and fear of asking questions. The research also found that quarantined children may be at higher risk for suicide. The limitations of the article is that the authors did not assess the parents' ability to apply the risk mitigation framework. The strengths of the article is that the model can be applied to any family regardless of socioeconomic status. Psychosocial impact of COVID-19 on children and adolescents. In the fifth article, the purpose was to synthesize literature on the psychosocial impact of COVID-19 among children and adolescents. The researchers used an electronic search engine to identify studies done up to March 2021 that reported on psychosocial and psychological symptoms resulting from COVID-19. This information was extracted using a predefined template, and a qualitative analysis was conducted using Strobe. 102 relevant papers were identified. They found that the impacts that occurred on children from COVID-19 are usually due to fear of illness and social isolation. This research was limited due to the available number of prospective studies. The strength of the study is that the article appraisal was done using Strobe. Public health preventative measures and child health behaviors during COVID-19. In the last article selected, the primary purpose was to determine the association between public health preventative measures and children's outdoor time, sleep duration, and screen time during COVID-19. Parents from the Greater Toronto area completed a questionnaire about the adherence to the public health measures and the children's health behaviors. Questionnaires were developed and administered either weekly, biweekly, or monthly. The results found that children's psychosocial health is negatively affected due to lockdowns related to things like increased screen time and detrimental sleep patterns. The limitations of the study were the biases that occurred due to the nature of the questionnaire used. The strength of the study was the cohort design and repeated measures used. Okay, so while I was looking at the literature, I found 4 big themes that stood out among the articles. The first theme was that the psychosocial impact of COVID-19 is greater on children than that of adults. This is because one of the reasons could be because children are not equipped with the same capacity to grieve as adults. Next, we see that restricted play created an environment of unrest and unrestricted development. Healthy movement is great for physical health, but it also helps improve mental health. During lockdowns, playgrounds were shut down around the world. Sports that kids once played were no longer allowed to be competed in. These limitations on physical movement and healthy competition can be contributed to the negative feelings that kids felt during lockdowns. Another resounding theme was the negative impact of increased screen time during lockdowns on children. While computers and other devices are important to keep children connected academically and socially, it did come with negative outcomes. One study showed that screen time beyond 5 hours a day strongly correlated with peer and social conduct problems. Increased screen time also brought upon disrupted sleep patterns. All of the articles gave recommendations on how to best combat the issues brought up by the recent pandemic. One way to do this was by studying past pandemics. This information can help improve child health and safety outcomes. Encouraging children to have an open discussion with their families about their feelings toward COVID-19 and lockdowns is a starting point towards avoiding major psychosocial health concerns. All caregivers involved in the lives of children should be diligent to identify behaviors and emotional changes so that early management can be implemented. So what type of effect does this have on nurses, and how can nurses help? Nurses should teach parents and guardians the importance of good sleep hygiene, healthy eating, and daily routines. Nurses are also in a very unique position to help identify mental health issues. One way is by regular screenings. Healthcare professionals should continue to provide standard and emergency mental health care. The pandemic setting may require professionals to be more flexible with how they offer these services, including the uses of technology and more individualized approach. Nurses should also be prepared with a suicide response. COVID-19 changed healthcare as we know it. Research on the psychosocial effects of COVID-19 and lockdowns has just begun. More studies need to be done to evaluate the long-term consequences. Healthcare workers need to continue to work with kids and their families about their feelings toward the negative social outcomes of the pandemic. Staying aware of the psychosocial issues COVID-19 brought on is important now and will be for years to come. These are my references. And does anyone have any questions? Oh, go ahead. So whenever we went to Laurelwood, there were several kids. There were like 7 kids there, and every single one of them stated a reason for being there was because of COVID-related issues, either spending too much time at home or their parents saying that they were spending too much time on the internet, talking like on Facebook and stuff, where a 12-year-old probably shouldn't be on Facebook all day. And then also I'm in the pediatric emergency room in Augusta, and we probably see in a 12-hour period, we see 8 to 12 psychiatric patients a day. This is ages, I think the youngest I've seen is maybe 11 to 21. And I asked the nurses there, and they said that this was not the norm 2 years ago at all. So, and then I know the CDC, some of this research was from last year. I know the CDC came out and said that 40%, that young girls, the risk of suicide for young girls has gone up by 40% in the last 2 years. So, Dr. Huff? Mm-hmm. Mostly, most of the stuff was like things that we should do before we get to that point, which is if we're spending a lot of time on our phones, if we're not keeping our day, and this was more, a lot of it was like during when we were under super lockdown, spending more time on our phones, staying up until 2 o'clock in the morning, and then waking up at 2 o'clock in the afternoon and keeping the daily routines, becoming more withdrawn from the family, not wanting to eat at family dinner table time with some of the stuff, or like even eating habits decreasing with some of the stuff that I read. So, alrighty.
Good to go.
Awesome.
Do a couple introductions.
Thank you. Here, I'll give you a handout. Okay.
Okay, we're going to get going. This is Abigale. We got timekeeper. So with green, you got 5 minutes. Pink is 3 minutes. Red, or sorry, pink is 2 minutes at least. And red is done.
Perfect.
Awesome.
Thank you.
Questions at the end and we can go from there.
Okay, sounds good. So yes, my name is Abigale. For my capstone presentation, we are going to be discussing disability awareness training for healthcare professionals. So for my question, I asked, in healthcare professionals, does disability awareness training improve health outcomes for persons with disabilities compared to healthcare professionals who do not receive disability awareness training? So you may be asking, what is the significance of disability awareness training? So 1 in 4 people in the United States will have a chronic or an acute disability in their lifetime. So that means just here in Georgia alone, 2.5 million people live with a disability. So as healthcare professionals, this is incredibly important because people who live with disabilities are going to be a majority of the population that we're taking care of in the hospitals, in the clinics, and just interacting with them in everyday life. So one fascinating thing that, I've kind of come across during my research is the fact that despite the fact that so many people live with a disability, the World Health Organization found that people with disabilities more than twice as likely to report finding healthcare provider skills inadequate to meet their needs, 4 times more likely to report being treated badly, and nearly 3 times more likely to report being denied care. Persons with disabilities are more likely to have poor overall health, less access to adequate health care, and engage in more risky health behaviors. So what's considered a disability? So the American Disabilities Act, or the ADA, considers a disability as a person who has a physical or mental impairment that substantially limits one or more major life activities. So for my first article, this article discussed the medical training that specifically doctors get within medical school. So this analyzed clinical findings of health outcomes of people with disabilities compared to physician bias and the cultural competency standards set by the Liaison Committee of Medical Education in medical schools. So this article found 28 peer-reviewed articles regarding attitudinal healthcare barriers to persons with disabilities and the prevalence of physician bias. So this found that a lot of medical students reported receiving inadequate disability training in their schooling, and as of 2011, only 7 accredited medical schools use standardized patients with disabilities. So obviously this is a huge, substantial finding. You think about it, we have probably hundreds of medical schools just here in the United States. And the fact that we, as healthcare professionals, are not training the future of healthcare professionals, how to interact and how to treat people across the spectrum, especially those with disabilities, is quite concerning. And this just kind of leads to the further health disparities that a lot of these people are focusing on. I know too, even in our nursing school studies, that we kind of briefly touched on some topics of, how to work with people with disabilities, but there was no, very broad education that we were given. So this study concluded that there's a disconnect between physician bias and the reality experienced by persons with disabilities, and this may be due to the poor disability education and medical training. So for my second article, this was a case study, and this was the degree of integration of disability rights into allied health professional education. I found it very interesting. A lot of the papers and the articles that I found were actually from Australia. So Australia was kind of very proactive within discussing disability awareness training. So this article explicitly explored the extent to which disability rights principles are integrated into the competencies and the education of the 6 allied healthcare professions at the University of Sydney. So this included nurses, occupational therapy, speech therapy, and a few more other allied health professions. So the data was collected by a quantitative keyword search of allied health professional competency in education documents. Interviews were then conducted for coordinators that focus on disability rights in the allied health professional areas. So this article wasn't necessarily, going out into the community and asking all these questions about how people with disabilities perceive their healthcare. This was more so an analysis of the education already in place by the University of Sydney. And this was also very interesting that the study found allied health professional competencies recognize the relevance of human rights principles to health professions, but to many varying degrees. So this data suggested health education may be insufficient in providing students with the knowledge to care for and protect the rights of clients with disabilities. So for my third article that I found, this was a point of view simulation of nursing students, and this was ranking their empathy scores. So this study was to examine the impact of an immersive point of view simulation on nursing students' empathy towards people with an acquired brain injury. So this study, they actually did not have someone with a real acquired brain injury, but they had actors step in and act as they were a patient with a brain injury. So this is a convenient sample of nursing students from 3 campuses of one Australian university. And so there were 390 students within this study. This study used a 2-group for a pre-test and a post-test. And then afterwards, they analyzed the empathy scores before and after the simulation. So as you can see, pre-simulation empathy scores were 0.61 and the post-simulation was 0.66. So the conclusion from this study is the results strengthen the hypothesis that the potential for a point of view simulations can positively impact learners' empathy towards persons with disabilities. For my 4th article, I have primary care for adults with physical disabilities, perceptions from consumer and provider focus groups. So this was to kind of figure out how consumers and educators perceive primary care for people with disabilities. So this wasn't necessarily for people who have disabilities, but more so for, you and I walking around who obviously don't live with a disability, how we think these people actually get good health care. So data was gathered from 3 consumer focus groups at sites reflecting urban communities surrounding the University of California, 26 of these communities, as well as focus groups of primary care professionals, and that was 13. Within this study, all of the groups perceived that healthcare professionals need more education about disability issues, and 4 major barriers were identified that limited the care. These barriers included a lack of knowledge, communication gaps, physical access, and funding. This is really important too, because I really love that this study recognized the fact that there are all of these other barriers that people suffer from who have a disability. And throughout all of the research, I've really noticed that a lack of knowledge about this topic is one of the biggest issues that we're facing. For my 5th article, Embracing Diversity and Accessibility, a Mixed Methods Study of the Impact of Online Disability Awareness Program. So this was a case study with a mixed methods research design and addressed the challenges persons with disabilities face in higher education. So this was kind of difficult because a lot of the research that I gathered, not much had been conducted in a healthcare outlet. So this was the one article that I have that was in an educational area. So this was an online disability awareness training program was created to address these problems that professors and students perceived. So by identifying these challenges and addressing professors' personal bias towards this population, an online disability awareness program was created for the school. The study suggested that an online disability awareness training of 4 to 6 hours improved the attitudes towards students with disabilities, and application of the alternative educational evaluations improved their educational outcomes. So strengths and limitations within my research. One strength was that a lot of the research that I found was a lot of systematic reviews. Everything was relevant in peer-reviewed articles. And then a lot of the studies also suggested other compounding factors that may affect the research, such as funding, socioeconomic status, and the person's location. Limitations, there is a lot of, all of the research is very limited. It was actually very difficult to find any professional articles talking about disability awareness training, especially within healthcare. Everything was a small sample size. So this, of course, is difficult to apply to a broader population. And then there's also varying definitions of disability. You know, people can have visual impairment, hearing impairment, physical impairment. So there's a very broad spectrum that disability encompasses. And also there were a lot of inconsistencies in the type of training that people received. So overall, I found an overwhelming amount of evidence that there's a great need for disability awareness training in the healthcare setting. However, there are many limitations and a lack of resources that keep this education from occurring. Additionally, sources such as the ADA, WHO, and the CDC provide ample amounts of data pointing to the need for disability awareness training, but not many strides have been taken to provide this education. In conclusion, undoubtedly, research has found the need for disability awareness training, and this is an important part of advancing the rights and access for people with disabilities. So I felt like we all needed our own disability awareness training. So this presentation I thought of this topic because of my dear friend Marcella. She has muscular dystrophy, and through like just really impactful conversations with her, you know, she's told me what it's like for her to go to the doctor and for her to receive healthcare. So I provided all of you guys with a handout, and this is just 5 very helpful rules to follow. So the first one being, talk directly to the patient, not anyone else in the room. Sometimes patients can come in and they have caregivers, but ultimately the caregiver is not receiving that healthcare. It is the patient that's getting that healthcare. So caregivers can be a great resource, but you know, in the end, it's that patient with a disability that's getting that that healthcare provided to them. Secondly, avoid assumptions based on patient's condition or disability. You know, just because someone's in a wheelchair doesn't mean that they can't have sex, and doesn't mean that, you know, they may need birth control or all of these other different things. So avoid assumptions. Use person-first language. I know as nursing students, or just healthcare professionals in general, it's easy to say, oh, the diabetic in room 3, or, oh, you know, that person, like they're paraplegic. But, you know, that person is not their disability. They're their mothers, their fathers, there are coworkers, there are peers. So, you know, don't boil someone down to a physical limitation. Repeat back to patients what you understood them to say. This is just great for clarification. And then don't finish a patient's sentences. There's nothing more frustrating, especially if you have a disability where it's difficult for you to speak, than someone, you know, interjecting and trying to finish your sentence. So with that, do we have any questions? Yes, Dr. Huff.
Article 5, you said it was about the higher education and online, and you mentioned that there was some issues, I guess issues with faculty and I guess the students. Can you elaborate on some of those problems that were mentioned in the report?
Yeah, of course. A lot of times, especially mentioned in the article, professors kind of felt, I guess, kind of like awkward in a sense when it's come to like coming up to a student and like addressing their needs, especially like if someone's in a wheelchair. So that was definitely like a very important barrier. And after having like a discussion with the professors and the students, like what was expected out of that relationship, that was one of the issues. And then also, it also mentioned about just students being afraid to speak up and ask the professors for what they needed, because there was such like a, you know, almost like a power dynamic between the professors and the students. So it really just boiled down to like a lack of communication. Do you have a question?
Do you think that implementing education like yearly in the hospital system as like just like an online course, or you think it should be like an in-person sort of like an in-person class where they like sit down and kind of go over?
I personally think that if you have, you know, a one-on-one experience with someone, then it's going to be more impactful. And then, I mean, like the online training, I mean, no one really goes, you know what I mean? Like no one actually sits down and takes to heart those educational opportunities. So personally, I think, you know, especially for us as nursing students if we had, you know, some sort of like interaction or someone with a disability come in and say like, hey, this is how I want to be spoken to. You know, this is how I want to be interacted with. I think that would be very helpful. And then, yeah, like a once a year training in person in the hospital setting, I think would be great. So yeah, that's it. Thank you guys.
Next, I think we have Hanna Peters. Good. Here, which one is yours? Peanut allergy? No, this one.
Yes.
What will your name on
Yeah. Possibly.
All right. Probably should let you drive.
Screen two. Sorry.
Is this the one?
Stop sharing.
Yeah.
I just need screen two.
All right. Share. All right, next up we have Hanna Peters. Same thing. We'll take some questions at the end. Go ahead.
So I did my topic on ICU patients, and my question was, an ICU patient has a risk of ventilated infection decrease in ventilated patients if they are using proper mouth care for the duration of intubation period. So the P for population is going to be ICU patients. The I is going to be the intervention, which was proper oral hygiene. And then the comparison is going to be patients that were not treated with the proper hygiene that are listed throughout the articles. And then O is going to be decrease in infection rates in ventilated patients. So the background is that the body is very susceptible to infections when the immune system is compromised. So to me, anytime someone's in the hospital, they're automatically, I guess, we're prone to getting infections regardless of what they're in there for. So nosocomial infections are infections that occur while in the hospital for another reason, which would be how they get pneumonia based off a ventilator, whether they're there for pneumonia or for another reason. One common problem in ventilated patients is the development of ventilated associated pneumonia. And then I've said pneumonia is the second most common nosocomial infection in critically ill patients, affecting 27% of all critically ill patients. 86% of nosocomial pneumonias are associated with mechanical ventilation and are termed ventilator-associated pneumonia. With ventilators, the oropharynx and trachea is compromised and leaving the patient higher risk for more infections. So how can we as nurses prevent these infections? And that would be through providing proper mouth care to the patients on ventilators. So I did preventative measures that are kind of all listed throughout the articles. So mouth care has been proven to be the most effective in decreasing the risk of infection with ventilated patients. So you want to also monitor for the readiness to extubate, suctioning of the patient's mouth to decrease secretion buildup and decrease the risk of aspiration leading to pneumonia, removal of biofilm, and using proper mouth products and tools. So all of these are found ways to prevent the rate of ventilator-associated pneumonia. So in Article 1, the title was Using Evidence-Based Practice to Prevent Ventilated-Associated Pneumonia. The purpose was to put protocols and practices into place to decrease the risk of pneumonia in patients that were intubated. They performed mouth care, elevated the head of the bed periodically, and monitored for readiness to extubate. The head of the bed was elevated to 30 degrees for majority of the stay unless the patient was sleeping. They did spontaneous awakening trials to see if they were ready to be extubated. They used suctioning and swabs in the mouth. In this article, they also mentioned the VAP bundle, which was used to monitor the mouth care done for each patient. A main problem with this article that they found was like non-compliance with nurses not really documenting or even like providing the mouth care or documenting that they did. So a lot of it was kind of just, they had proof that people were doing it, but not really for sure if they're doing it the right way, if they were only doing like one of the ways that they like mentioned in the article that they were going to try to do. And a lot of them use the VAP bundle to like make the nurses have to like put that as like a priority for their ventilated patients. In Article 2, the utility of endotracheal aspirate bacteriology in identifying mechanically ventilated patients at risk for ventilated associated pneumonia, a single center prospective observational study. The main purpose was to use endotracheal aspirate to help identify patients that were starting to develop some type of infection. They watched how highly the sample taken from the trachea colonized. The detection of Staph aureus in the ETA preceded the onset of VAP by approximately 4 days, offering clinicians time to identify and characterize the bacteria and apply prophylactic measures. By identifying the start of bacteria growing, they were able to deliver prophylactic treatment before pneumonia occurred. The main purpose they were trying to accomplish was that using these measures to set like a scheduled protocol for each person, and also each person had a different protocol. So if they were there for like something to do with their lungs is the reason why they were intubated, they had like a different protocol than a patient that was there for like another reason that led to intubation. They also did a certain charting method for compliance with the nurses. But finding the bacteria like helped decrease the number of VAP patients, but they did treatment before the patient was symptomatic. So they would start like prophylactic antibiotics, or I guess like a lot of them mentioned like extubating earlier to hope to decrease the effect. So in Article 3, they did a randomized control trial. It had 28 patients all over the age of 18. Getting the secretions out will help in preventing the infection because the glottis remains open as the vent is in the patient, so aspiration is very likely. So the main point of this article was the oropharyngeal secretion volume in intubated patients, the importance of oral suctioning. So the purpose was this article showed how preventing the presence of oral secretions can help decrease the risk for aspiration to the lungs, which could set up infection. They started to conduct research by seeing the outcomes of suctioning the patient at 2 and 4 hour intervals. The suctioning was set at 100 to 120 and placed the bed at 30 degrees. Therefore, oropharyngeal suctioning may reduce the risk of aspiration and ventilator-associated pneumonia. Studies have shown that when oral suction was part of a comprehensive oral care program, rates of ventilator-associated pneumonia decreased. So in this article, they tried to set up the same method. So the head of the bed was 30 degrees. They used the same like pressure of suctioning, and they also made sure that they did it at 2 and 4 hours, which I feel is like efficient because you chart in the ICU mainly every 2 hours, and then your 4 hour intervals were also just to do like more times. So in Article 4, it was the impact of tongue biofilm removal on mechanically ventilated patients. The research was conducted to see if scraping the biofilm off the tongue would lead to a decrease in infection rates. They had 50 participants, 27 were in the control group and had mouth care performed, and then 23 participants had no mouth care. In this study, there was a decrease in tuberculosis. Only 9 of the 27 patients had positive microbial cultures before and after the use of the tongue scraper. Even though all of the patients weren't successful, it did seem to help overall. And being in the ICU and seeing like the mouth open pretty much all the time with the vent in the mouth, you see how it grows on like their lips, their tongue, like just anything inside their oral cavity is basically growing like a film over it. So I think it's very important to make sure that you're doing oral mouth care, regardless if it's 2 hours or if you just go in the patient's room and you see that that's happening, like you can just suction them out or wipe them with a swab. So Article 5 was outcomes of an oral care protocol in post-mechanically ventilated patients. The purpose was put a protocol into place for nurses in the critical care unit to use for patients that were intubated. In this study, the focus was on lips, tongue, gums, saliva, smell, and mouth comfort. Previous protocol was the use of Toothette and bicarbonate toothpaste. The new protocol put into place was the use of a battery-operated toothbrush, Colgate Clean Mint toothpaste, a tongue scraper, Crest mouthwash, and a lip balm care. They took bacteria cultures on day 4 and 8 of the study and seen a significant decrease in the intervention group that was treated with the new protocol. So I feel like for this article, they mainly just use like certain things. That way they could track it over time to see what was used the most for each patient, to see how they had a better outcome than the patients that they did like the first protocol, which was the Toothette and the bicarbonate toothpaste. So this was kind of a summary that was found throughout all of my articles, and the common theme was found in correlation between diligent mouth care and a reduced incident of ventilator-related infections. So no matter what protocol or mouth care they did, it all ended up in a decrease in infection rates, the most critical intervention to the patients that are hospitalized, and especially intubated patients, in the use of proper mouth care. Those are my references.
You have any questions?
Have you seen the effects of like the intubation and like correlation between intubation and basically what you're talking about? Like, have you seen that firsthand in your clinical experience?
I think so. I've seen a lot in the ICU now is like to see more, like I didn't really think that they would like do the readiness to extubate like every day, but they really do. Like the respiratory therapists are in there suctioning, cleaning out the mouth, and then seeing how the patient's breathing on the vent. And then also like us as nurses going in and basically not knowing if they have done it yet. So we're kind of doing it too, which I feel like is a good preventative way to make sure it's getting done continuously and not just like by one person every 2 hours.
From what you like have read and everything, what would you recommend? Like suctioning twice a day, or like how much like oral care do you actually need? Like once a shift or once every 2 hours?
I would say at least every 2 hours.
Okay.
Because definitely in the ICU, because that's mainly where your vented patients are. Like you're charting every 2 hours, like their RAS score and like all that. So to me, that's a good time to go and put in that you did do it. But like for the last one that was using like the toothpaste and like the electrical toothbrush, I just kind of feel like it also is putting them at risk for choking, because unless you're like suctioning and doing it at the same time, it's kind of like it could put them at a higher risk. But I do think at least like the swabs with like some kind of mouth cleaner or something would be efficient every 2 hours.
Yeah, I was just wondering, you were saying, searching, are y'all like cleaning the devices, every 2 hours?
That is like where I'm at. Respiratory therapy does that. So I know that they go in and change like the inner cannula out. I don't think it's done every 2 hours, but I think it is like once a shift. But I do know that they do take it out, clean it. But I think every day it's replaced with a new inner, like the cannula that goes in.
One last question, you know, we know the protocol is every 2 hours to get that mouth care. Have you noticed that nurses are really doing, you know, how sometimes, you know, the food, you know.
Yes. Like I know it goes with like turning the patient every 2, and like sometimes that doesn't happen. Truthfully, no. I mean, but also when you have a very critical patient in one room and then you have one that's like kind of stable, and then like, you know, your main focus is on the really critical patient. So it's kind of like, I don't know, I just feel like some of those things are put at the bottom, but then you don't even realize the effects that it had that you didn't go in there and do it, that in the long run, it really could affect your patient.
With that being said, do you have an idea of how to reinforce that and ensure that nurses?
I feel like if you go in and turn your patient, and like where I'm at, like we don't do our own vitals and stuff, but if you were to have like your set priorities of like what you have to do, like turning your patient or changing your patient, like I just feel like that should become like a routine that everyone includes. Like, I know I have to do this. Like, you know, you have to give your meds. Well, while you're in there, why don't you just do it? You know what I'm saying? Like, I feel like just making sure that as a nurse, you have your own routine of making sure you do it is a good way.
So which one of these is yours?
It probably says grace on it. It's the peanut allergy
No,
one.
yep.
I go by 2 names.
Gotcha. Let's be complicated. I did the same thing. I think we can just do the.
Okay.
Right here?
Yeah.
Okay.
Awesome.
Yeah. All right. Take it away.
Good afternoon, everybody. My name is Grace McCartt, and today I will be discussing if the solution to preventing peanut allergies in children is actually found in the problem. So raise your hand if you ever grew up with someone that had like a peanut allergy, like you were in like kindergarten and you know, my friend can't have peanuts or something like that. See, most of the class has been exposed to that. So really since the 1990s, peanut allergies have been like the increasing rate of allergies within children and also the leading cause of anaphylaxis in children. So go into a little bit more of a background of what's happening to kids when they're exposed to peanuts if they have an allergy. Basically, the immune system produces antibodies, and when the body doesn't like something or thinks it's under attack, it will release these antibodies in the body to send off a response, say, no, we don't want that. So that's basically what's happening with the kids that have a peanut allergy. They have antibodies against peanuts, and then once they have it in their system or anything like that, their body like basically just freaks out on them. So they can have a mild reaction such as like a rash or like rhinoconjunctivitis, which is like a runny nose. But the big issue at hand is shortness of breath and anaphylaxis. So when a kid has anaphylaxis to a peanut allergy, their airways can constrict and that can potentially cause death. So that's the biggest risk in this poor baby. He's having a reaction to peanuts. You can see his face is swollen and other things, that angioedema is cutting off his airway so he can't breathe due to the allergy reaction to peanuts. So the question at hand is, does early exposure and prevention during childhood prevent the lifelong allergy to peanuts? So my population is focused on children. There's an exposure, non-exposure group to peanuts, and also the outcome is decreased peanut allergy rates. So my first article, both of my first articles actually go over exposing kids during infancy. So the first one was a randomized controlled trial over 640 infants from 4 to 11 months old. So this study, they had a group that had early peanut exposure. The other group did not. And they wanted to see the effects if, you know, the early exposure had decreased peanut allergy rates, which it did prove that the early exposure group only had a 3.2% of those children having a peanut allergy rate. And then the ones that did not have exposure or were delayed after that first year actually had 17.2% of their kids have a peanut allergy. The second article as well is a randomized controlled trial. And this had 1,303 3-month-old infants. Again, like the first article, had an exposure, non-exposure group. But the second article was really interesting because they did like a double-blinded placebo food challenge. So after they were exposed, it was from 12 to 36 months old after the children like had grown up a little bit, and seeing if the allergy rate had anything to do with that exposure early in infancy. And it showed the early exposure group only had a 1.2% allergy rate in their kids, and the delayed exposure group actually had more peanut allergies at 2.5%. So my last three articles I had actually exposed, it looked at the exposure of peanuts during pregnancy and breastfeeding. So the first one is probably my favorite article. It had 1,344 mothers and their children. And these mothers specifically had 5 weekly servings of peanuts. And they only had 6 kids come out with peanut allergies. It was so cool because it looked at not only early exposure during pregnancy and breastfeeding, but also the amount of peanuts that you can consume while you're pregnant has a greater effect and decreases the likelihood of peanut allergy as well. My second article was actually a cultural study. So it looked at different culture backgrounds in the United Kingdom. There were 655 Libyans and then 264 Libyans that lived in the United Kingdom. Then there are also 264 United Kingdom natives that partook in this study. And basically it looked at how culture background can affect allergy rates in peanuts as well. Like, you know, if that's in your like ethnic and cultural background to expose kids or not during breastfeeding or pregnancy or during infancy. So actually United Kingdom group had the lowest amount of peanut exposure during pregnancy and breastfeeding. And they had 2 per 640 cases of kids come out with a peanut allergy, compared to the Libyan group who had the highest amount. It was 90.7%
of the mothers exposed themselves to peanuts during breastfeeding and pregnancy, and they only had 3 cases per their 655 that partook in the study. The last group was really cool too. So their mothers were reported 58% of them consumed peanuts during breastfeeding, and then they looked at the kids at the age of 7 after that. So they followed up with the kids after 7 years since the study was performed and looked at, control versus exposure, non-exposure. And the non-exposure group actually came out with 11.6% of their children having a peanut allergy at the age of 7. And then the group that had that early exposure during infancy only had 6.8% of their children have a peanut allergy. So some major strengths to my articles were large population sizes. So none of my studies really had small sizes, like they were like hundreds or thousands of mothers and children that partook in the study. So it made it great to apply for like overall populations. And also with the populations, there were also different culture backgrounds. Like I had articles that took place in the United Kingdom, I had them in the United States, and also in Canada as well. And every study I had an exposure and non-exposure group. So there was a cause and effect with each study, whether you had peanuts or you didn't have peanuts. So that was a great strength with all my articles. Also with Article 1, we had the pediatricians review the medical records of the children who had the peanut allergies or didn't, to verify, to make sure they actually had a sensitivity to the peanut allergy or not. And then my first 2 articles were randomized controlled trials, and that decreases the biasness of the results that occurred with those 2 studies. Now, there were limitations within my articles, especially the first 2 articles. The kids had pre-existing allergies such as eggs, or they had eczema. So the researchers discussed how that could affect the peanut sensitivity rate in the children, if that occurred or not. And then the second one also had other allergies exposing the kids exposed to, such as cow's milk, eggs, while they also exposed to peanuts. So that could also interfere if they were really sensitive to peanuts or not. One of my articles that looked at pregnancy and breastfeeding, I found really interesting because they said fruits and vegetables that the women ate could affect the peanut allergy rate in their kids. It didn't go into detail on why, but I guess during that consumption, I guess it could interfere with like antibodies being produced or something like that. It didn't go into great detail, but I found it very interesting. And also genetic factors. Some people, their families just have a history of peanut allergies in general, and you can't really do anything about that. And then the biggest limitation throughout all my articles, the early exposure groups proved that it decreased the peanut allergy rate in children's doubling and tripling it, but it didn't cure the problem. We still have the problem of peanut allergies, but the early exposure groups proved that it can decrease the rate by so much that it's just going to help people overall and help kids not go to the hospital, not have those reactions, and also be able to eat like peanut butter cookies and stuff like that. So how does this apply to nursing? We are advocates and we are advisors. We have to advocate for our patients, but also the future patients that we're going to have. So by doing like education classes for pregnant women, or even in like pediatrics, we can advocate for them, for the patients that we're going to have, and just say, eating peanuts during pregnancy, breastfeeding, or before they start to build those antibodies can decrease the likelihood of their kid having a peanut allergy, especially if they're more susceptible to having an allergy to peanuts, like if it runs in the family or something like that. You can't help it, but it can help in the long run. Especially if we do promote early exposure, it can decrease the peanut allergy rate of kids going to the hospital or having an anaphylactic reaction and then potentially death in kids. So absolutely advising mothers and parents of new babies coming to the world, or if they're trying to get pregnant, on the benefits of eating peanuts, and also working with a dietitian with the pregnant women and how that can benefit them. And then I leave you guys with a question, because this is what I thought about the whole time I was looking at all my articles, and just that what other food allergens can be pre-exposed and prevented. So since peanuts were building up the antibodies during infancy within that 6 months,
if we're exposing kids to peanuts during that time, then what other foods like shellfish? I know that's a big deal for a lot of kids. They can't have shrimp or other kinds of nuts or cow's milk or eggs. If we can pre-expose them as well, will it decrease their allergy rates as well? And then of course, I talked about peanuts, so I had to include something from the peanuts in my PowerPoint. But does anybody have any questions?
Your studies that did like the different cultural
Mhm.
backgrounds, were they looking at more like a genetic, like is this more like genetic in the culture, or was it still just like pre-exposure?
It was more so not more of the genetic factor, but more so since they were different cultural backgrounds, like how they, like what foods they had, they presented to their kids, what was like culturally acceptable for them kind of thing, like more so like a familiar, like, oh, we don't eat peanuts, or it was like with my family, like we don't do certain things because that's just like our cultural background, more so that, not more genetic factor.
For the kids, like I understand you pre-exposure to like prevent the allergies from developing, but like the kids that do develop the allergy, like is there like a certain age range where they typically like develop a peanut allergy? Like
So most of my studies, they verified if the child had like a sensitivity to peanuts or an allergy after that year of infancy. Because most of the time women, if they chose not to expose their children to peanuts, or if they did, they waited until that first year. So after that, that's when a lot of like tests and studies were done. They did like skin tests in the first article. That's what the pediatricians verify with that medical record to see if they really had a sensitivity or not. So after that 1 year is when most of the kids were verified, but also with that one study, it looked at kids at 7 years old. So really, it's like, you don't want to test it and have your kid have a reaction, but most of the time it's after that 1 year because the mother or the parents have not chosen to expose their child to peanuts. And then once they do, they might have a reaction to it, and then you'll be verified with that allergy.
This is more of a comment. When I first got pregnant, back then everyone gave people the book what to expect when you're expecting. I don't know if that's still in y'all remember that book. And basically I remember very distinctly said like not to eat peanuts and stay away from different things. So that's very interesting because it was very popular back then. So a lot of people are probably getting that information and staying away from these different allergies when in fact it sounds like they should be exposed.
Absolutely. I know personally, my parents exposed me to everything when I was a kid. Probably stuff that like my dad gave me like Dr. Pepper as like yeah, I was supposed to do that, but I personally don't have any allergies, but my parents were very open. I have friends who when they were an infant, their parents did more like organic things or like didn't have soy in their diet. And now they have an allergy to that because they haven't been exposed to that. Their immune system doesn't know what it is. So it kind of freaks out on them. And it's like, oh no, this is something bad for my body, which it's really not. But definitely since the 1990s, the rates have increased. So maybe like the studies have been performed and it shows that the exposure should occur to prevent those allergies from occurring. Anybody else have any other questions? Thank you very much.
Lara,
Or a master. It's a great name. You could be like a protagonist in your own like crime drama series.
Maybe. We just hit the space button to move it.
Space or you can just do
Or
it.
the arrow.
Okay. All right. Take those in.
My name is Lara, and my presentation is on workplace violence and the effect on nurse burnout. Stop moving. There we go. Okay. So my Pico question was, does workplace violence increase burnout in nurses in acute care settings? So acute care settings are mostly hospital settings and like mental health settings. So my population was the nurses in acute care settings.
if their workplace is violent or non-violent, and the effects of burnout and how quickly they're like ready to move on and change jobs. So a little bit of background is workplace violence for nurses is a growing epidemic that nobody really talks about. You know, we hear all about our pandemics and our viruses going around, but nobody really mentions anything about workplace violence. It can come from patients, family members, and sometimes even your own staff. Most hospitals have safety protocols put in place, but we're wondering if they are really working. So I know personally, the hospital that I work at, before COVID times, you had to take a de-escalating violence class. So you had to show up in a room with security, and they taught you how to somewhat defend yourself if you ran into a violent situation. Most hospitals have those. And then reporting. Reporting is a really big factor. You don't really see many cases. So are nurses actually reporting? Do they feel safe enough to report? And are those being passed on to where you can clearly see an issue and something's done about it? I really love this picture because it says you punch a cop, you get arrested, you're going to jail. A bus driver, arrested, can't even use the transportation system anymore. A bartender, you're drugged out of the bar. A nurse, they're like, what could you have done differently? Where did you go wrong? Not, is your patient have dementia? Was your patient intoxicated? You know, was your patient just rude? They're looking back at you. So are nurses feeling safe enough to say something to their management? Are nurses just expendable? We'll just replace you if you don't feel safe here and you quit. So types of abuse, physical, of course, verbally abuse, getting cursed at, the emotional trauma that goes into it after a hard shift of, are they having de-escalation classes? Are they providing that aftercare after you have a violent patient? Are they providing like a debriefing situation for you to step out and be like, what just happened and how could we have prevented it? Threatening and intimidating behavior, and then harassment, verbal harassment, sexual harassment from patients. My first article went over how violent patients were observed in the terms of physiological and psychological health of nurses in an emergency department. So it had 235 participants over a 12-month period, and they were all given a questionnaire to fill out. The findings were over 50% said they had lower, decreased job satisfaction because they were working in a higher, more violent workplace. My second article examined the prevalence of workplace violence towards newly licensed nurses. This is actually my favorite one because it followed new grad nurses within 3 years, 312 of them. And at the end of the 3 years, they got a psychosocial questionnaire that asked them what kind of violence they were facing, if it was physical, verbal, what they thought was the most prevalent, how they could have de-escalated situations and caused like less violence in their workplace. So all types of violence were found in the findings, and it related to a decreased job satisfaction when analyzed. And those are just new grad nurses within 3 years. Think about a nurse that's been in it for 20 to 30 years, how they would feel. Ooh. My third article was a systemic review. So it had, my article 3 is a comprehensive baseline of workplace violence in a Canadian province. This one was my highest amount of participants. It had 462 participants, but they weren't just all nurses. It was doctors and other healthcare professionals within the acute care setting. They all got emailed out a survey to fill out. And I think they started with 5,000 participants and only 4,462 actually sent back the email.
99% of them saw violence or physical assault. So the study found acute care nurses that worked in emergency departments, psychiatric, and medical surgical specialties reported the highest prevalence in their study. Article 4 was my systemic review. They started with 300 papers and weaned it down to 31 peer-reviewed articles that showed a correlation of workplace violence bringing on anxiety and more stress, leading to less job satisfaction in working nurses in acute care facilities. Mainly the ones you saw were nursing homes dealing with dementia patients, mental health nurses dealing with psychiatric patients, and then emergency care nurses. They're dealing with all of the above. They also get, alcohol withdrawal patients and things like that. Article 5 was one of my just kind of baseline studies that really underlined the cause. It investigated the prevalence of workplace violence and the effects of burnout in mental health nurses. So mental health nurses are dealing with all your kind of psychiatric patients, but they also deal with more of like your detox patients and stuff like that as well. They had 599 participants. It was a convenient sampling method, just a 30-item questionnaire developed by different protocols that they followed. They found that 265, which is 44.7%, almost 50% of those nurses had experienced workplace violence in the past 12 months. So that's over 50% of your staff has experienced violence just within 1 year. The number of participants at the highest risk of compassion satisfaction was 332. So you're seeing that decrease in empathy, that decrease in compassion, which could lead to decrease in care and overall just horrible job satisfaction. My Article 6 was violence against nurses from the perspective of a women's hospital. So it was just a very small study, but it sat down and they had 45-minute actual interviews. So it wasn't just a questionnaire that you filled out. They actually had interviews and talked about how those nurses were emotional when they were talking about the violence that they had come across within their years, sexual assaults, all kinds of different violence. So 74.1% of those nurses faced violence at the work, and 64% said mostly it was verbal abuse from their patients. So most of my studies were surveys, questionnaires. They were given out for people to participate or not and send back in. I think that's kind of a weakness because they're direct questions. They're not open-ended, trying to find out what's actually going on. And then all the studies that I found showed direct correlation between workplace violence and a decreased job satisfaction, which decreased job satisfaction means you're going to burn out faster and you're going to be ready to move on to something different. Workplace violence is causing high stress situations, anxiety. People don't even want to go back, lower job satisfaction. And I thought it was very interesting when I was doing all my research that I could not find any articles US-based. 5 out of my 6 articles were overseas studies, and the other article was in Canada, which technically is not overseas, but it's not US-based. So I was thinking, is it just not funded here in the United States? Is it kind of swept under the rug? We're just not talking about it. I found that very interesting. And then my conclusion is better protocols should be put in place, more safety for the nurses and the working environment. They should definitely have debriefings after you're basically attacked by a patient, whether it's verbally attacked or physically attacked. You should have some time to debrief and calm down and go about the situation in a better way. And then, of course, more studies should be done stateside and see how our hospitals are facing violence. Any questions?
do you have, like, this is a personal question. So, like, have you had any experience with, like, workplace violence where, like, you felt either you could say something or you just felt like there's no point in saying it because nothing's going to be done?
So I work on a neurology floor with a lot of altered mental status patients. And so we see violence all the time. We've had quite a few nurses kicked, hit, just all kinds of stuff. And at night shift, we usually get the residents that are on call and they're like really nervous to do anything about it. So at what point, like, do you go higher up and say, like, this is what needs to be done? People are getting hurt and it's not safe. So we see that a lot. They try to like avoid restraining the patient, but we see it a lot.
In any of your articles, did it talk about like the presence of like police officers and like the ER and like the violence, like with that, like it, having like a safety officer there, like decreased violence?
So none of my studies that I found talked about security. Some talked about safety protocols, but that was it. Nothing said anything about like actually having like security put in place, like, and what they would do in a situation.
I haven't personally seen like another nurse get like abused by someone, like they changed their care for that patient because of that experience.
So I saw a nurse get kicked in the head 2 weeks ago. And he went down to the ER and got scanned and they sent him back up to the floor and said, you can still work. He has not had the same drive in the last 2 weeks to really care for his more critical patients. So I thought that was interesting. It really correlates around with my study.
I was wondering about demographics. Is it more likely a female will experience that violence, or did the literature say anything about male versus female?
Not necessarily. I didn't see any kind of correlation to like if it was male or female. And a lot of my studies didn't specify, just that one specified that this was women. All the other ones just said participants and like talked about like their jobs, like they were either nurses or techs or doctors. They didn't really kind of hash out genders. Yeah, it was a male. Yeah. So it really happens to anybody, especially if you're dealing with altered mental status people that don't really know where they are, who you are, what you're doing. And those Americans.
How's it going?
Good. How about you?
Not bad.
Have any instructions for me?
Super disappointed you didn't bring in my.
Oh, I'm sorry. Yeah.
My whole day is gone.
Oh, yeah. Oh, yeah. And actually, I used it this past weekend. I had to spend a night party.
Then you have
I
to.
used it.
How's it going?
Good. Problems with it?
Well,
It's like the whole
shape, like the whole thing was kind of went away, but Zoom is still open.
Yeah, so yeah, it's good. All right, so one of the things I've noticed on this, see how your controls are up here now. So what we're gonna do is we're just gonna, let's go up to stop sharing. See how it, and now we should be able to go.
So she's taking over.
Okay.
So we're here. And okay,
doing that
I'm
one.
gonna just do this one. That way it makes it easier for me to. All right, so see, here's their image. It's sharing, so they're ready to go. Sometimes you might have to go back and click on this because the arrows won't work if you don't click on this. You may have to do at least the first one, and then they can use the arrows.
Okay.
So,
All right.
we're good to go. Let's just make sure. Make sure it's not one up to see.
Can y'all see okay? Do y'all want to look and see?
Yes.
Everything's good? And so he said the arrow should work, but if for some reason not, you can click right on there and it should work. Okay. And then I'm going to tell him to have questions at the end.
Yes,
Okay?
and we have a slide that says the questions.
Oh, okay.
Yes,
Okay,
ma'am.
perfect.
Yes.
Do you have any questions?
I think you're ready.
227, shall we start?
Yes, ma'am.
Okay, and y'all know about the timing.
Yes. Yes,
Okay,
ma'am.
perfect.
Hi, good afternoon. My name is Dr. Susan Winstead. Thank you guys for coming today. I'm so happy we have 4 wonderful presentations in here. The first one, Lauren Lowe. Lauren. Yay, Lauren Lowe. And Harlee Yarbrough.
Yes, ma'am.
With hand sanitizer versus antibacterial soap, which is better. And it's you guys where you've got a timekeeper, I believe, in the back. Here, perfect. And she's going to let them know 5 minutes the green, and then when there's 2 minutes left, the pink, and then the red means you went ahead to question. So if you guys will just hold your questions until the end. If you have phones, please make sure you put them on silent. And I think that's it. Oh, Lions Ground. If you would like, if they do fantastic job, please let them know. I'll see you on the line. And you can get to that using the QR codes over here. And please make sure that when you come in, that you've got the QR code to show your
Ma'am.
I'll turn it over. Thank you so much.
Hi, I'm Lauren Lowe,
And I'm Harlee Yarbrough.
and we are presenting our findings from our antibacterial hand soap versus antibacterial hand sanitizer experiment.
So hand sanitizer and hand soap are both things that we use on the daily. Everyone uses them, I hope. So have you ever thought about if you've used more hand sanitizer more often, or if you use soap more often, like kind of which one may be your preference? COVID-19 has actually, as you probably know, brought more awareness to washing your hands, as well as even hand sanitizer, just doing it more and more often, just to help keep minimizing germs. So that's why we decided to do this experiment, just comparing each one to one another and seeing which is more effective.
So to give some background, we looked at a study that was done in Indonesia. This study was done with a group of school-age children, and it showed that hand sanitizer was more effective at killing bacteria than the hand soap. The difference with this experiment than ours was they actually rinsed their hands off before using the hand sanitizer, which could have had an effect on why the hand sanitizer was more effective. And then a study done with a group of dental students showed no real significance between the using hand soap versus hand sanitizer.
So so the materials that we used were very minimal, just to keep the experiment as accurate as we could. So to begin, we used soft soap antibacterial hand soap. And then for antibacterial hand sanitizer, we used the brand Extra Care, and then just 8 nutrient agar plates to perform the experiment.
So the procedures we used, first for the antibacterial hand soap, I labeled the plates before. We used 2 before plates for the hand soap and 2 after plates for the hand soap.
So then once she labeled the plates, I dirtied my hands by wiping them on the bottom of my shoes, on the ground, on the desk, just anywhere around that has a lot of germs.
So after she got her hands dirty, I held one of the plates labeled before for Harlee to place her hands on, which she rubbed her hands all over the plate to get a full coverage.
And then that's when I washed my hands with the soft soap and made sure to allow my hands to dry very well after I washed them, so that when I did the next plate, the after plate, it was nice and clean and accurate for full coverage results.
Yes, and again, she touched her hand to the after plate, making sure to get the complete coverage. Then we repeated the all the steps for a second replication and incubated the plates for 24 hours. So the hand sanitizer procedure was very similar. We again labeled 2 plates before, 2 plates after. Harlee did the same exact procedure for dirtying her hands that we did for the hand soap. Then we contaminated 1 before plate, just like the previous experiment.
And then the main difference here was that I cleaned my hands with extra care antibacterial hand sanitizer rather than soap.
And then again, Harlee touched 1 after plate. We repeated all these steps for a second replication and incubated the plates for 24 hours. So before we show the results, are there any guesses on maybe what the results may have been? Okay. So let's look. So this was our before soap. So this was the plates that Harlee touched after dirtying her hands on the floor. As you can see, there's like pretty full coverage all over. And then this was the after the soap. So on the top one, it was pretty effective. On the bottom down here, you can see the 2 big shapes. We actually are pretty sure those are all 1 colony, just water made them spread out. So still pretty clean.
Effective, yeah.
So
for this one, this was the before antibacterial hand sanitizer. Again, like we mentioned before, just made sure to dirty my hands very well and rub them over these plates for full coverage. And as you can tell, we were able to get that. And then for our results, which are pretty shocking, there was not much effectiveness that occurred for this plate. We still had just about as much coverage, if not the same. So that kind of concluded our results for this experiment.
So this is our results in graphical form. The back 4 that are yellow was the before plates, and we determined there's about 80% coverage on the plates for all 4 of the before. And then the green, the first 2 are the hand soap after, which you can see about 1% on 1 plate and about 20% coverage on the other plate, and significantly higher coverage on the 2 hand sanitizer plates. So what could have been done differently in our experiment?
So one of the first main differences is that we could have used different brands. There are lots of different brands out there for both soaps and sanitizers. So one may be more effective than another. Therefore, we could have tried different brands other than the ones we chose.
We also could have done more replications. Since we were doing this during our allotted lab time, we only had a certain amount of time to do replications, so we couldn't get too many done, but that could have been done differently.
Same for this one, very similar to replication, just the number of test subjects, we could have had more of them just for more effective results. But again, because of our time in lab, we were only had a select few subjects with what were in the lab cabinets.
And then finally, we to get more of an accurate result, we could have tested the type and number of colonies. So what specific bacteria was growing on the plates, because some of the bacteria that was left over could have been good bacteria. But again, we don't really have that material to be able to do that test, but in future experiments that could be done. So in conclusion, we found that hand soap was obviously more effective at killing bacteria than hand sanitizer. That, however, doesn't mean we should quit using hand sanitizer. Maybe we should start using them together more instead of replacing hand soap with hand sanitizer.
So these are our references, just where we got our extra information from.
Yes, and so are there any questions?
Yes, ma'am.
The results really show us that we need to be washing our hands with soap and water.
Yes,
Yes.
ma'am. Yes.
Yes.
What are you going to do with those results? What can we do here at Pico with those results?
I think we can definitely encourage people to wash their hands more, maybe have like signs up like reminding people to wash their hands, which of course you see those all around anyway, especially like in restaurants that people have to. But definitely I think we can definitely need to push people to wash their hands. Maybe we can even put signs on the hand sanitizers in the bathroom saying, hey, maybe this isn't like,
Just basically like telling people that.
yeah, be like, this maybe isn't the best, like just a warning, be like, this isn't gonna completely kill the hand sanitizer, wash your hands as well.
And even with just like Piedmont being such like a type of community, like word by mouth, just like telling friends to tell friends, telling professors to tell students. This is definitely the environment of just like friends and just like a big community. So even word by mouth, like it could definitely make a big difference. And even just sharing these results and telling others like, hey, hand sanitizer is not working as well as we think in some experiments. So yes, ma'am.
Any other questions?
Thank you.
Thank you so much. Next, we've got Allie Powell, toxic shock syndrome. I didn't notice it wasn't bad twice. Okay.
Oh. Do you have an account? Uh-huh.
No. I don't know why I do that because I saved it as a nice and
I don't know if they'll take my account or not. And so all right, do you know how to play it from here? I need to share the screen. Yeah, so I think if you just hit the down button, it'll work like that.
okay. Oh, that's nice.
Oh, but you can't see it.
I'm not sure this is
screen too. Let's try it. She's got Adobe, and so I was able to sign in on my account, but I can't get it to show. Pardon the technical difficulties. How'd you do that?
The only problem is, you have to kind of operate it from looking at that, if that makes it,
Okay,
is it okay?
sure.
Um,
If she hits down, will it work? Or does
yes.
she have to hit right on there?
So let's try it now. So you can actually use it up and down.
Oh,
So
perfect.
now let's do this though. Let's go to our sharing. Screen sharing.
We did have it on screen too, but I don't know.
Oh, you did? Okay,
I
well, that's
think so.
perfect. Then, 'cause that's this. So you're good to go.
Okay.
Just hit that.
So we might need you when we go back to the.
It's fine.
Okay. Good afternoon. I'm Allie Powell, and for my presentation, I researched toxic shock syndrome. Okay, to start off, I'm going to be talking about what toxic shock syndrome is. It's a rare, life-threatening complication of certain bacterial infections, and those bacteria include staph, strep, and Clostridium sordelli. It's also abbreviated and just called TSS, and it's most common in women that are menstruating due to the association of menstruation products such as tampons. Some symptoms of toxic shock syndrome include fever, headache, rash, and the shedding of skin in large quantities, which is often seen within 1 to 2 weeks of the initial onset of toxic shock. Chills, muscle aches, and if toxic shock syndrome is acquired by like a surgical procedure, it's usually acquired within 3 to 5 days. But if it's from such thing as a tampon, it's usually between like 12 hours after the initial symptom. Some treatment options for toxic shock include giving intravenous antibiotics, giving intravenous fluids to treat shock and also to prevent organ damage. Also, heart medications are given with people that have low blood pressure, and dialysis may be required due to sepsis that may have been caused by toxic shock, and also giving blood products such as blood transfusions. The cause of toxic shock, it could be caused by many different things, but it's most common from leaving in a tampon in for longer than 8 to 12 hours, which is longer than the recommended period of time that's advised. And as I said before, it's caused by the bacteria staph or strep, and it could be caused by having a recent surgery, having a viral infection such as the flu or chicken pox, also having cuts or bruises on your skin or a deep puncture wound. Some ways that you can reduce the risk of acquiring toxic shock include changing your tampons regularly, at least every 4 hours, to reduce the buildup of bacteria, which causes toxic shock. Avoid using super absorbent tampons, which is kind of what I said before. If you're using a super absorbent tampon, it's going to increase the risk of just absorbing that bacteria all in all. Only unwrapping a tampon if you're going to use it immediately because of just kind of the bacterial aspect of it. Bacteria can build up on a product that you're going to be putting into your body. So only unwrap it when you're about to use it. Don't handle the tampon more than you need to. And lastly, wash your hands
before and after use. And that's it. Well, there should have been one more slide, but it's not on there. So, okay, that's all. I should ask if there's any questions.
Percentages of different age brackets? Who's most common to get it? Is there any study that says a certain age is more common?
I didn't read that in any of my research, but I would guess probably a younger age groups now, because I did read that younger girls now are getting their period actually a lot like sooner than people did, let's say 50 years ago. The age bracket is just going lower and lower for when you're first getting starting your period. And so I would assume probably the percentages would be towards that younger age bracket, because it's hard to have, I guess, I don't know, in schools, like the education of the proper use and how to use things. And so, yes, my guess would be the percentages would be.
Have you read any studies to show if we have less now than we did 10 or 20 years ago? Because it changed so much over generations. Any difference in the number of women who get it today versus the number of women who got it 50 years ago?
I didn't read too much into that, but I did read about it's more common like for women now to not have a period, and that's due to like birth control per se, or even like the fertility rates have decreased from a decade ago, like astronomically. And so that could definitely affect it, because obviously fertility, you need your menstrual cycle to allow everything to happen. So yes. Yes, I agree. Any other questions? Sorry, I didn't hear.
I'm sorry, she said fifth grade. That was kind of usually the grade where that happens. Does that need to happen sooner than that?
I would say so. I mean, I know a lot of girls that even get their menstrual cycle in third grade. And that could be really scary for younger kids. I mean, if you're informed about what that is, it could be a very shock. So yes, I would think elementary school. I mean, probably not kindergarten or first grade, but I would say second grade, third grade, just introducing, not getting even in too much depth, but introducing what this is and what happens and why it happens would be valuable information for younger females.
Thank you.
Yep.
Thank you.
Okay.
We need the salmonella one. So here. Katie, there's two. Which one's Katie? Okay, if you want to come up, there's actually two saved for you. So I assume it's the one from the second. The latest one. Would that be the latest one?
I don't know why there would be two, but
Okay.
look.
Okay, I assume it would be that one then.
Yes, ma'am, I'm guessing. Okay. I'll tell you.
So I want to go to share next. This one or screen two?
Just screen two.
Okay.
Yes, ma'am, that's it.
But we can't
And you
see.
start, yeah.
Hey, welcome Katie Ogle with Salmonella. Thank you. That sounded weird. She does not have salmonella. But she's got a presentation on it. Thank you.
So my name is Katie Ogle, and like she said, my presentation is over salmonella. The main causes of salmonella actually come from the food we eat, like chicken or eggs when they're not cooked properly or cooked all the way. Also handling live poultry, whether that be if you're handling your backyard chickens or if you grow them commercially and you're coming in contact with them, touching them with your hands, holding them close to your face, it transfers that bacteria very easily. A very rare way that it actually transfers is between person to person. You come in contact with someone with an active infection, you have the potential of catching it, but it's a very rare way to catch it. This diagram shows which foods actually transfer salmonella the most. And as you see, that's poultry, obviously, and eggs behind that. But other foods also can transfer, especially like in plants or anything, if they come in contact with salmonella from any poultry meat or anything like that, that can be contaminated onto that meat. Some symptoms: salmonella shares symptoms with other food poisoning diseases that you can get. Chills, diarrhea, fever, nausea, vomiting, abdominal pain. The treatments are antibiotics. You'll be prescribed an antibiotic to help kill the bacteria. And then keeping your body hydrated and eating healthy foods kind of helps you deal with the symptoms, not necessarily the bacteria itself. The way that a salmonella infection is detected is you can go to the doctor and they'll perform a physical exam, and then they may also take a stool sample, a blood culture, and then they'll use that to test for the antibodies. So what is happening on a microbial level? The salmonella bacteria actually come into the mucosa of the small and large intestine, and they release toxins that actually cause those symptoms like vomiting, abdominal pain, and it can actually lead to the destruction of that mucosa. So did you know that salmonella is one of the most common food poisoning, that a lot of people come in contact with it sometime in their life, and it affects millions of people all over the world. And like I said before, the close contact with backyard chickens has increased the number of salmonella infections. More and more people, especially with COVID, they were at home, they wanted to get a new hobby, they get backyard chickens, collect their eggs, and they're not washing their hands, they're bringing them close to their face, and you just have to take those extra precautions to be careful. So that was all. Is there any questions? Yes, ma'am.
What areas of the world have the highest salmonella rates?
Oh, I did not find that in my research, but if I had to guess, I would assume maybe some third world countries that maybe don't have the cleanliness or the ability to disinfect stuff as well as we do here, or the plants that it's made in might not be as clean as it is here.
What exactly do the farmers do to protect themselves? I mean, they're with it 24/7. So what do they do?
Yes, ma'am. Actually, I live on a poultry farm, so everyone has special shoe coverings, and when you go in someone else's chicken house, it's not your own, you have to completely cover in full body suits and gloves and everything of that sort, but lots of washings of hands. That's around my house. It's a lot of hand washing before and after, really, because we don't want to give anything to our chickens either. So, and then after, and the chickens are actually tested for how high their salmonella levels are. And then also the meat is also tested again once they're in the plants. All right, well, thank you.
Whitley, thank you so much. And I would love to get a picture of you guys at the end but I can send her that instructions if that's okay. So she couldn't be here, okay? I did already text her that y'all are doing a super job, so thank you. So good job.
Okay, well, my name is Whitley Ward, and I'm talking about H. pylori. Okay, so H. pylori is a disease, and it grows on the inside of your stomach. Mainly the lining of your stomach is what it destroys. It's a spiral-shaped bacterium that can cause a lot of pain in the abdominal area, but it also can cause pain like your whole body in aches, fevers, all those kind of things. Like it's not just in the stomach area. And this is also something that you could have and you could never know until it just flares up in your stomach. The symptoms include aches, abdominal pain, loss of appetite, and weight loss. It can also be like hair loss, kind of like the same thing of you just not eating. So symptoms can also go off of these kind of symptoms. And treatments, they'll tell you to take antibiotics, or they'll tell you to be on the brat diet, which includes bananas, rice, applesauce, and toast. And that's for about 2 weeks. But if that doesn't help, there's really nothing else that they can do. You just kind of have to deal with the pain. There's no exact cause for this, except that it comes from food or it comes from other people that you have been in contact with. And it is a reason for ulcers in the stomach and stomach cancer. So how does this disease affect you? Like I said, it can cause ulcers in the stomach. It's swelling or inflammation in your stomach and the lining of your stomach. And it can also cause cancer. But the ulcers basically are how you lose your appetite and weight loss. So the frequency of the infection is about 30% of the countries in the world are having cases of H. pylori, and it's going up year by year. The frequency of the disease is between 80 and 97%. It requires complex growth media, and a small host is found, and it's been found in humans and non-humans, and it's a gram-negative bacteria. There are also many tests that can test for H. pylori, but you can also have this and never know. So you could go to the doctor and get tested for things, and then H. pylori shows up. But some examples include a blood test, a stool culture, and upper endoscopy. Any questions? Yes, ma'am. Well, basically it's just bland foods, because acidic foods are what makes the ulcers like flare up in your stomach. And that is what is from H. pylori. And so it doesn't have to be just bananas, rice, applesauce, and toast, but for at least a week, it has to be just that. And so, I mean, it's just calming your stomach and stuff in your stomach and like trying to flush everything that's in your stomach out. I have no idea. I actually have this. And so the first time I ever heard it from the doctor, I was like, I kind of asked him the same thing, and it was an acronym that they made up. It helps people remember, especially kids. So, yeah. Okay.
Thank you guys so much for coming. Please round of applause. And the finale for taking the picture. So thank you guys. Great job. Y'all don't take all of take a picture. Yeah, do you want us to stand up? We'll get together. I'm not able to sign in. Did you do it on the keyboard? No. Okay, it was on the keyboard. Can I get one here? Yeah, you do. Okay. Oh, you're beautiful. Perfect. Thank you. All right.
Leave that playing.
Yeah, because this is the last session of the day. And then who's the first? Oh, I didn't bring my catalog with me. Hold on. Make sure I remember who's first. We do have one that was missing from the, OneDrive folder, but she's got it loaded down here, so it shouldn't be a problem. That's the last, I think that's the last one of the day. So I'm 310, so we are with Ashley Arnold Bonds, I think. Maggot debris. Correct. Yeah. Is it Bonds? Is that the correct way to do it? Okay. Oh, I like the maggot. That's a cute maggot. What's, that's just, that's our next side. Okay. All right. Yeah. Okay.
I'm gonna do this one.
Yeah.
Let's do this one next.
Okay. There we go.
Because it keeps that here.
Yeah.
So the light was where
So she should be good to go.
Yeah, she should. Yep. Okay. All right. Thank you so much for this. Are you heading out or are you
No,
gonna?
I'm gonna stick
Oh, bless you. Oh, sorry, I'm walking around. Sorry, yeah. All right, judges, we're about 2 or 3 minutes before. I think we have all our presenters, so it's okay. We'll get up and get going. That's all right. So judges, judges, okay, judges in the back. I'm also your room assistant today. So everybody already got their t-shirt and did everybody get their?
They were with the shirts, so I just put them in front of each of them.
Okay.
Their certificates, and I don't know whose all those are.
Okay, we'll get them to the right people. They must have missed it from the other session. All right, well, this is Ashley Arnold Bonds. She will be presenting today maggot debridement therapy in diabetic patients with decubitus ulcers. We're from the School of Business and I'm learning all sorts of new words today. So thank you very much. And are you comfortable and ready to go ahead? Okay, thank you so much.
Okay, so as she said, my name is Ashley Arnold Bonds. I am a senior nursing student in the R.H. Daniels School of Nursing. So take a good look at this guy before we get started. How many of you have seen or dealt with maggots before? Okay, so for anybody who's in nursing, if a doctor came in and said, hey, we're going to do maggot debridement therapy on this patient, what would you do? So if you're like me, you're probably going to put maggots in that category with everything creepy and crawly, right? So okay. So having said that, if you have a weak stomach, this may not be the presentation for you because that cute little guy on the previous screen is probably the cutest maggot you're ever going to see. So in diabetic patients, they have something called neuropathy that is caused by their high blood sugar, and it can lead to decubitus ulcers. If you are familiar with diabetics, you know the one warning that they get is to never walk around your home with your shoes off. Always wear your shoes. And the reason for that is that neuropathy is a type of nerve damage that can cause sensations of burning tingling and numbness. So if you're a diabetic and you're walking around and you drop the cup the day before and you cut your foot, if you're having that numbness, you're not going to feel that cut. And if you can't feel it, you don't know that it's there. And if you don't know that it's there, you don't treat it. And so it just kind of gets worse. Diabetics have about a 15 to 20% chance of developing an ulcer in their lifetime. So not terribly high, but still, that's not something we want, because decubitus ulcers are the leading injury that leads to amputation in diabetics, and nobody wants to lose a limb. So once these decubitus ulcers happen, there's delayed healing by factors such as circulation, infection, and comorbidities such as stroke, heart disease, kidney failure, and eye damage. So all of those can affect how that ulcer heals. And then diabetic foot ulcers, or DFUs, are difficult to treat. They cost between $7,000 to $10,000 per ulcer, and like I said, ultimately require amputation. So you don't even get the full body package, right? It's $7 to $10 per ulcer. Conversely, maggot debridement therapy, you can get a vial of maggots for $98 plus shipping and handling. I'm going to say that 2 or 3 times because I don't like to spend money. So that's an alternative to going with that standard $7,000 to $10,000 treatment. And like I said, it's less expensive than medical and surgical treatments, and it can even be obtained if you're really, really squeamish in maggot confinement dressings for a simple, safe application to that wound. So having said all of that, I decided to do a little bit more research on it because I'm like, this is interesting. How is this going to work? So maggot debridement therapy is a wound therapy that applies live medical grade larvae in a controlled environment to encourage debridement, disinfection, and growth promotion activity. And the main species that is normally used is the green bottlefly, Lucilia sericata. That's what you're typically going to see. And again, you can get these vials for $98 for shipping and handling. And it is a modality used only after conventional techniques have been exhausted. So if you have a decubitus ulcer, if you go to the emergency room, they're not just gonna push maggot debridement therapy to the forefront. They're gonna try everything else first before we get to that. So you still got options. So in order to conduct my research, I came up with a Pico question. And that question was, what are the effects of maggot debridement therapy in adult diabetic patients with decubitus ulcers? My population was adult diabetic patients. My intervention was maggot debridement therapy. My comparison was MDT compared with no MDT. And my outcome, we were looking at healing time, time to healing, and incidence of infection. So in order to obtain these articles, I utilized the Galileo database accessed through Piedmont University Library. I used the search parameters of maggot debridement therapy, decubitus ulcers, diabetic patients. And the inclusion articles, they had to be scholarly articles that were peer-reviewed that had been published within the last 10 years with a cutoff of 2011. They had to be written and published in English. As much as I would like to speak another language or read another language, I cannot. And then they were assessed, for internal and external validity. So I chose a total of 5 articles. And the synthesis of that literature revealed that maggot debridement therapy is a safe and effective modality. There were very minimal drawbacks to it. I think one of the main things were when the maggots could not gain access to the wound, they couldn't do their job. It has an ability to achieve wound healing by, again, debridement, disinfection, and growth promotion. It has the ability to battle antibiotic-resistant bacterial strains, 2 of which are Staph aureus and P. aeruginosa. Those are 2 of the main culprits that cause ulcers in diabetic patients. They assist in bacterial elimination through digestion, production of antibacterial excretions, and destruction of biofilms. So I just want to break that down just a little bit more. So debridement is less traumatic to the skin tissue than surgical methods. It also, that debridement occurs by the mouth hooks of the maggots, and they have rough bodies. So that works together to kind of scratch up that necrotic tissue and help that debridement to occur. And then they actually secrete enzymes that kind of liquefy that necrotic tissue. That's actually what they eat. So if you're like me, I kind of thought they had teeth and they ate tissue, but that's not the case. And then their excretions have antibacterial properties that destroy the biofilm of bacteria. And if you're familiar with bacteria, you know that that biofilm actually protects them from destruction. However, with all that being said, it should not be considered a first-line treatment. Why? There's just not enough research. We need to do more research. It is more cost-effective than traditional treatments. 7 to 10 versus $98 per vial plus shipping and handling. I will keep saying that. And again, additional research is needed. So, gross pictures, I'm sorry. This is a patient who had a very nasty decubitus ulcer. This treatment occurred, I believe it started in December, so a total of 6 months. This is how it looked before. And this was after the application of maggots. One of his chief complaints, as you could see, you can feel them moving. So if you don't like creepy crawly sensations, might not be the best thing for you. But despite that, here in January, you see we've got a lot of red tissue. We've got a lot of new growth, a lot of healing going on. And this is by May. So he had gone through a lot of other treatments that had not worked for him. And with the application of these maggots, he was almost able to completely heal this wound. And I should note that these treatments, the number of treatments that you have to have with maggots are dependent upon the severity of the wound. So what are the pros? They can heal wounds, again, that have failed to heal with more conventional methods. Healing occurs through debridement, disinfection, and growth promotion. Again, we're looking at preventing that Staph aureus and P. aeruginosa. And they can also be antibiotic resistant organisms. Inexpensive, $98 a vial, y'all, just saying. But how does it affect nursing? Well, the question I asked at the beginning was, if you are a nurse and a doctor walks in and says, we're going to do maggot debridement therapy, are you equipped for that? Probably not. But with continued research, it can lead to policy development and training for nurses. Because if you're going to use this with a patient, you need to know how to do it. If you're me, you're going to have to get over being like skirmish about it. And that was the issue with some of the providers who participated in these studies. They were really squeamish, kind of grossed out, guys included. So what are the cons? Again, additional research is needed. Why? The sample size. A couple of the studies that I chose only utilized one patient. We know there's more than one diabetic in this world. Patient comorbidities. So they've got a lot of stuff going on. So we don't know how those other health issues are affecting the healing of that ulcer. Provider and patient education. Most patients don't know a thing about maggot debridement therapy, and if you tell them, they're probably going out a window, myself included. Most providers don't know about maggot debridement therapy. So if you tell them about it, they're probably gonna like kick you out their room or something, I don't know. Then there was the patient discomfort and or pain, but it was not a pain that could not be controlled with pain medications. So nothing severe. So I found this interesting. There was an exclusion of uncontrolled diabetics in research. Just gonna let that sit there for a minute. Because in most instances, your uncontrolled diabetics will probably be the ones with the cutaneous ulcers. Not to say that controlled diabetics don't get them, but it's more than likely going to occur in an uncontrolled diabetic. One study used multiple treatment modalities. So we had MDT, we had some pharmacologic therapies going on, we had some non-pharmacologic therapies going on. So you had all of those interacting that could have affected how that ulcer was healing. The length of clinical trials, again, this is going to vary because it depends on the severity of the ulcer in the patient. So some patients may require only one application of maggots to their wound. The patient that I showed you in the previous slide, he went through 6 months of it. So again, it's going to depend on the severity. So for the research, you kind of need to get patients that are going to have to require the same length of applications, I think, for it to be more valid. Difficulty in obtaining maggots. I don't know about y'all, but I don't know too many people who have a maggot farm out back. And no, you cannot go throw a piece of meat outside in the hot sun and go grab the maggots off of it. Doesn't work. And then there's a small time window for use. They must be applied to the wound within 24 hours. So if your patient says, I don't know, let me think about this for a couple of days, you're not going to have maggots by the time they make that decision. So those are just some of the cons. And these are my references. Does anybody have any questions? Okay.
How do you get them out? Like once you put them on, how do they remove them?
So one of the modalities that, because most of the experiments that I saw, it was an application of 25 to 50 and the most 100. I've read that they use tweezers, which is time consuming. And then some of them use gauze to kind of block them out. I think that kind of varies depending on how they were applied or whatnot. So those are only two ways that I read of how they were applied or removed. I'm sorry. Dr. Davis. So it really didn't specify. It just said physicians and nurses, but it didn't make a distinction as to whether that physician was a surgeon or whether that nurse was specifically a wound care nurse. I think the articles that I had were just healthcare professionals in general. I do know that a couple of studies had wound care nurses on board that were kind of monitoring, but I don't know to what extent they were included in the application removal. I think they were just kind of overseeing the application removal by the physicians and the nurses.
Those uncontrolled
Mm-hmm.
patients, if you did clarify that they are the ones that could be more at risk for this diffuse ulcers that would necessarily be benefiting, because ultimately, they're going to be having some application.
Mm-hmm.
How were they able to select? I know they have some inclusion and exclusion criteria. How were they able to select their participants? How did they advertise to get their participants to, really participate in these studies?
So in a couple of the studies, there were flyers that were going around. I know at a couple of diabetes clinics, they would actually go talk to the patients like, hey, we have this alternative therapy. Would you be interested in participating? I don't really know. And I think with another study, it was just patients who had wounds that were not healing. And they would go to them and say, hey, we've tried everything that we can possibly try, with the exception of amputation. We do have this alternative treatment that we could try. Are you interested? So some of it was the healing length of the wound. Some of it was by flyers, and then some of it was just verbal and talking to patients.
They are mainly the fall into that vulnerable population of the poor, so many underlying conditions. So you will think that this type of intervention, one, is inexpensive and still can pay
$98.
So you think that more research will be done to promote this type of interventions to be able to address the needs of those high vulnerable populations that have so many issues that they don't have access to healthcare, they don't have income, and all kinds of things. There's a lot to be done with this stuff.
It is. It's, I think some of it too is probably societal. Like most people aren't, you say maggots, they run for the hills because they're like, that's gross. You're not putting that on me. I don't want to be in the same room with it. But I think that's where education is going to be key in educating them like, hey, I know it's gross, but these are the benefits of going through this therapy. So I think, like you said, additional research and additional education to patients and providers is definitely going to be key. I don't know that it will become something that comes to the forefront anytime soon, but I think it's definitely something that should remain on the table.
That's very old medicine. No, my grandmother talked about it. Yeah. She was from the lowlands of South Carolina, and back in the 20s and 30s, they used to do that. So it's very old medicine. But very good. All right. So I'm sorry, I should be a little bit more careful here about. So Jessie Gillespie in student nurses and education preparation. Oh, okay, this is all organized. Hold on. So I've got to go over here. Share. Student nursing and education. I think it's trying to figure out what's doing here. Sorry, y'all. We're having a little trouble with meeting control. It did this to me last time too. I think this one didn't close. Hold on. So we've got to give me this 1 second here. Let me try this one more time. All right, we might need to call IT again. Oh, hold on. I think I figured it out. There we go. Okay. Just a moment. So we would like, of course, now you go by Gabby? Yes, okay. Gabby Gillespie will now be presenting student nurses and the educational preparedness of patient death. So if you're willing to take the floor, and judges, are you ready for the next round? All right. Okay.
Do you want to take a photo?
Oh, yes.
Okay. Sorry, it's for a graduation thing. So I am Gabby Gillespie. I am a senior nursing student here at Piedmont University, and I decided to do my research on student nurses and the education preparedness of patient death. Okay, so my Pico question is, in nursing students, what is the impact of education on coping strategies of end-of-life care on their mental illness, on their mental health? So my Pico is, my P is nursing students, my I is education/coping strategies of end-of-life care, comparing to not having any education or any coping strategies of end-of-life care. And my outcome is improved mental health and positive coping strategies. Okay, so a little bit of background. With nursing, we are given extensive knowledge on pharmacology, on how to
disease processes, nursing processes, and organ function. However, end of life coping strategies, we are barely given any. Do you guys remember how many were given, or how SIM lectures, anything like that, were taught specifically on how nursing students are supposed to deal with patient deaths? Once. We had 2. So we had a SIM, which still isn't a lot. So we had SIM last semester, which focused on patient deaths, and really we're providing postmortem care, not how we handled it as nurses. And then we had a brief lecture this time last semester with a 20 PowerPoint slide on how we're supposed to deal with patient death with Dr. Anderson. So not a lot. So a little bit of background of why I chose this is my first patient that I lost a OB patient. So in the clinical setting, she came in, she was having trouble with, she hadn't felt her baby kick in a while, and we go back to see, and the baby's no longer with us. So having a little baby pass is a little bit harder, I think, for me than an older person, but it makes it worse is that I knew the person. So as nurses, yes, we have to learn how to deal with patient death, but as a person, you also have to deal with learning how to handle that death as a friend. But with nurses, we have to take care of that person. So you have to rein in your emotions and continue working. So that's why I chose this as my topic. So I have 5 articles that I chose, and they all pertain to patient preparedness. And so my first article was Influence of Training on First-Year Nursing Department Students' Attitudes on Death and Caring for Dying Patients. Article 2 was Death Education, Sensibility for Caregiving. Article 3 was Nursing Education, Students' Narratives of Moral Distress in the Clinical Practice. Article 4 was the relationship between death, anxiety, and attitudes towards the care of the dying patient and nursing students. And my last article was the effects of a death preparation education programs on death anxiety, death attitudes, and attitudes towards end-of-life care among nurses in convalescent hospitals. So I hit the key points with my articles. So the purpose of the first article was to determine how effective proper coping strategies education contributed to the nursing students dealing with end of life in the clinical setting. The students were asked to complete a pretest on how they felt providing end of life care, and then they were received proper coping strategies. However, with this article, it did not say how long the training went on, just that it dealt with first year nursing students. So it could be a year, it could be 1 semester, we don't really know. And then at the end, they were asked to take a post-test to see how they felt while providing end-of-life care. The main results showed that the education training for the first year nursing students received a effective in forming positive attitudes and less anxiety. So how does it relate to my Pico? Any type of training regarding end-of-life care for nursing students positively impacts their mental health outcome when it comes to end-of-life care. My second article, and the purpose of this one was to teach coping strategies for nursing students, how they could mentally prepare for it. So with this one, the professors actually went into clinical settings that were more likely to experience a patient death and walked through the students through scenarios. They did sims with the students, much like we did here. And then at the end, they were asked to complete questions and surveys on how they felt mentally and physically prepared. So back again, the results also show that any type of training with end-of-life deaths were shown to produce a positive effect in the mental health of the nursing student, and they felt more prepared to care for a dying patient and more prepared to handle their feelings after the patient had passed as well. So relevance to my Pico was that with increased education on end-of-life care, student nurses have a more positive mental health approach when it comes to care for dying patients. My third article, which was one of my favorite articles. So basically the the professors asked the students to write a story from your clinical perspective, which we have done multiple times, and experience which one has upset or challenged you the most. And what they found was that people who have passed impacted the student nurses more than any other clinical situation that they expressed. So the results showed that nursing education should be emphasized to a greater extent than just competency and training in challenging situations. So even though they didn't specifically in this article give coping strategies or teach them how to deal with it, it still showed that the ones who had lost patients wanted that extra structure, extra teaching to help them further on in their practice. So my fourth article was to examine the relationships of student nurses' mental health about death anxiety related to the end of life care. Now, death anxiety comes with one who has experienced end of life care, just regarding the death in general. So they use a death anxiety scale and the Fromart scale attitude towards care of the dying scale, which basically just meant how their patients died and how they dealt with it in the clinical setting. So the relevance to my Pico is that educating positive coping strategies to deal with the patient decreases the mental anxiety the student nurse might have while caring for the dying patient. Then my fifth article, and the purpose of that study was to examine the effects of mental preparedness of the student nurses while dealing with end-of-life care in your clinical settings. So this one was the most extensive. It lasted for 10 sessions twice a week for 5 weeks. So this one consisted of lectures, videos, discussions, and had a bigger impact on the student nurses. So the results showed that student nurses who attended the death preparedness education had significantly less mental stress and anxiety while caring for the end-of-life patient and felt better prepared on how to cope. So the relevance to my Pico, again, was just that any type of training on end-of-life care positively impacted the student nurses and their mental health. So how can we implement some of this into our nursing programs? You can implement courses such as simulations, which we did, and more lectures on how to probably cope with end-of-life care, how to positively assist a grieving family, because you're also not just dealing with the one who just passed, but you're also dealing and trying to calm the patient's loved ones as they just lost someone they care for. How to give the patient you just lost while checking on your other patients, because you have to, unfortunately, you have to go to the next patient even though yours just passed. And being able to process your feelings as you're walking to the next door. Sometimes you don't have a long time to grieve. And so going to clinical sites that one is likely to experience patient death. I know we went to Hospice House with Community last semester, and I really enjoyed that one. I think we need a little bit more of that just to help you better prepare, or even oncology centers. I think that would be a really good one to go experience. And even in the ER, I know we didn't get any clinical time in the ER specifically, unless you were just a lucky one who got it on a whim. And then just having a grief counselor available after you experience a loss, just to talk about your feelings if you need it. You may not need it, but just to have them there so you can know that they are there. And so the common theme throughout the article was proper end-of-life education, training, and coping strategies. The mental health of nursing students was significantly improved. And student nurses who had extensive education on proper coping strategies on how to deal with patient death had a higher mental health outcome than those who had not had the in-depth education training. Even if it was just theoretical, they improved. And those are my references. And that's it. All right, any questions, comments, concerns? Are we good? We're good.
it was more on the back of during the lifetime of the end stage, there's very little, really. So, that's a really concern because some people, we fail to realize that humanistic aspect of us nurses also, we have to do with our emotions to deal with it. And until you experience it, you have no idea what emotions will come up, or how you're going to handle it. Because I do remember my first patient that passed away 20-something years ago. You panic and it's like you shock me that, oh, this is it does happen. And you don't even know what to do in front of police. Then you're right, that counseling. Because yes, we focus on some hospitals, even though yes, you have the pastoral care will be there for the family members, but the nurse also needs some support,
Yeah, that's why I chose it. So,
I'm just thinking that we're on the generational cusp of that we've got that huge generation that are now in the 60s, 70s, and 80s. That it's a very large group of our population that's on the older side now, that plus COVID, Really runs it through. All right, thank you. At this time, I would say, don't forget to sign in, like I did. I don't know, sign in. So, that's session 3. Where's session 4? Yeah, there you go. Okay. We'll pass one down that way. So don't forget to sign in for session 4. Thank you. And let me go ahead and let me get you all set up there. All right, it would be very bad if I just sign in. All right, and I'll get you all set up here. Okay, so what we've got to do is we close this. There's a logic to all this. Oh, there's a chat question. Oh, okay. Will do, Ms. Smith. We've got a request to repeat any question from the floor. I guess some folks are watching it. So let me close that. Okay. Professor Smith. So, all right, and then let me make sure we've got this all set. So, you are Kathleen, correct?
No.
Nope, that's you. So are you the PowerPoint down here? Okay, sorry about that. See, I should have known better. That one. All right, let's get the editing done. All right, and then let me go here to, I think I have to, well, I'm trying to remember, do I need to push that first? There we go. But I don't, you know what I didn't do? Let's shrink that. Let's see, let's go to Zoom. I've got to make sure to screen share it. See, that's why I probably dropped the ball. So there's your presentation. Right. Okay. Oh, I've got it up twice. It's all right. Okay. What? Hold on 1 second. I do apologize. All I've got to do is master the screen share here. No, that's okay. It's my fault. I think that's it. There we go. Okay. Are you up and through? All right. At this time, if the judges are ready, or do you need a moment? Okay. We'll try to bring it back around to you here at the next session. And we will have Chelsea, is it Patak? Peacock. Chelsea Peacock will be presenting mammograms, the positive and negative effects. And I hereby cede the floor, and you've got your timekeeper.
Hi, my name is Chelsea. I'm a senior in nursing school here at Piedmont, and I did my research topic on mammograms, the positive and negative effects. Okay, so what is breast cancer? Breast cancer is a disease in which cells in the breast grow out of control. There are many different kinds of breast cancer. Most breast cancers begin in the ducts or lobules. When breast cancer spreads to other parts of the body, it is said to have metastasized. My research question is, are mammograms more beneficial or harmful in women ages 45 to 75? So here are some statistics about breast cancer. Breast cancer is one of the most common cancers globally. Breast cancer is the most diagnosed cancer in women throughout the United States. It is the second leading cause of death by cancer in American women. Many of you know somebody that has been affected by breast cancer, either indirectly or directly. It is said that 1 in 8 women will develop invasive breast cancer in their lifetime. There are more than 3.8 million women with a history of breast cancer, either currently being treated or have completed treatment. All women's risk of breast cancer nearly doubles if they have a family member who has ever been diagnosed. Finding breast cancer early reduces your risk of dying from the disease by 25 to 30% or more. So here are some risk factors of breast cancer: getting older, genetic mutations, reproductive history, dense breast, which I will discuss later in my presentation, a family history of breast or ovarian cancer, previous radiation treatment, not being physically active, drinking alcohol, and taking hormones such as estrogen or progesterone. Some warning signs of breast cancer include a new lump in the breast or underarm, thickening or swelling of part of the breast, irritation or dimpling of the breast skin, redness or flaky skin in the nipple area or breast, pulling in of the nipple or pain in the nipple area, nipple discharge other than breast milk, including blood, any change in the size or shape of the breast, and pain in any area of the breast. So, one of the best and most efficient ways to check for breast cancer is by having a mammogram. A yearly mammogram is a simple way to detect breast cancer. A mammogram is a relatively fast procedure and women have minimal to no discomfort. A mammogram involves taking a picture of the breast to determine if the breast is cancerous. Women who receive a mammogram and find breast cancer early are more likely to keep their breast. It is also important to perform self-breast exams on yourself. You know your body the best, and by doing this simple task can help save your life. Most national screening guidelines suggest that women should have mammograms starting in their 40s to maximize the benefits of detecting cancer at an early stage, and continue once a year if you are in good health. The CDC states women 55 and older should switch to mammograms every 2 years if they choose not to continue yearly screening. Most women are diagnosed with breast cancer in their 50s. Only 17% of women are diagnosed less than 50 years old. In the article titled "Breast Cancers Found by Yearly Mammograms" involved 232 women aged 40 to 80 years old. The study was designed to determine the effects of women being screened for breast cancer every year and every other year. 200 women in the study had mammograms every year, and 32 women in the study had mammograms every other year. The researchers concluded that women who had mammograms every year were more likely to be diagnosed with stage 1 cancer than women who had mammograms every 2 years. 44% of women who had mammograms every 2 years were diagnosed with stage 2, 3, or 4 cancer, which is a more aggressive type of breast cancer. Women who had mammograms every 2 years also had larger cancers than women who had yearly mammograms. Women who had mammograms every year had an average tumor size of 1.4 centimeters, and women who had mammograms every other year had 1.8 tumor size. Women who had mammograms every 2 years also received more aggressive treatment, such as chemotherapy or axillary lymph node surgery. 12% of women who had mammograms every year, compared to 19% of women who had mammograms every 2 years, had axillary lymph node surgery. 28% of women who had annual mammograms, compared to 38% of women who had mammograms every 2 years, had chemotherapy. This evidence shows the importance of women getting screened early and annually instead of every 2 years for breast cancer. The next article discusses the importance of annual and biannual screening. The sample size of this study was over 93,000 women between the ages 40 and 85. The study showed that for all age groups, women who had annual or biannual mammograms had a lower risk of dying than women who had less frequent mammograms or no mammograms at all. In women 50 to 85 years old, annual mammogram was more beneficial to lower mortality rates than biannual mammograms. It was especially noticeable in the group 60 to 74 years old. The article also informs readers that women should begin mammograms at age 45 and biannual at 55, as long as they have a 10-year life expectancy. Now, there are some limitations to mammogram screening, such as exposure to radiation, false positives, and false negatives, which I will discuss in the next few slides. In the 2016 journal from the Internal Medicine, they found a small risk. There is a small risk for annual mammograms in women. The study showed 16 deaths were caused by annual mammograms, predominantly caused by low dose exposure over the years. This was further researched into concluding women with larger breasts must have multiple scans or extra views, leading to greater radiation-induced breast cancer. However, the same study showed that 986 women were saved from breast cancer by having yearly mammograms. Therefore, the benefits outweighed the harms. One of the main concerns about mammograms from breast cancer screening is the chance of receiving a false positive test. False positives create a different sort of problem from women, such as undergoing additional testing or biopsy procedure. A false positive mammogram may look abnormal even though cancer may not be present. The risk of experiencing a false positive on a mammogram test is about 20%. This causes unnecessary costs to be placed and additional testing. This also causes the woman to be potentially put under a tremendous amount of stress. Some women also reported they had distrust in the healthcare system following a false positive test result. This actually happened to my mom. She was told she had to go under additional screening when she had a mammogram. And most insurance companies only pay for one free test a year. And so she had to pay out of pocket for multiple additional screenings. False negative tests can also occur in test results for women who undergo mammograms. A false negative test looks normal even though breast cancer is present. A false negative test can be very harmful because the woman has been told she does not have cancer when she really does. This puts her at a very high risk to developing serious problems for breast cancer because it is not detected in the screening. Women with dense breasts are also more likely to get false negative results. The picture on the slideshow shows the anatomy of a breast. Breast density reflects the amount of fibrous and glandular tissue in a woman's breast compared with the amount of fatty tissue. Dense tissues can hide cancers, which can be very harmful. People with a higher risk of dense breast include women who are younger, pregnant or breastfeeding, taking hormones, and having a lower body weight. In the journal titled Mammography in Women Older Than 75 had over 1 million participants in the study. So with all the research being done of the benefits and harms, should women stop receiving mammograms at a certain age? Specifically, should women 75 years and older stop receiving mammograms? The study was conducted by the Harvard School of Public Health and proved that there is no benefit in continuing annual mammograms over the age of 75. The study showed the 8-year risk of breast cancer was 5.5% in the group that continued screening and 3.9% in the group that stopped screening. The risk was 5.3% among women 70 to 74 and 5.8 in women 75 and older. The difference is so minimal that it shows virtually no reason to continue screening for women over the age of 75. Conclusion. There are risks of receiving mammograms such as low dose radiation, false positives, false negatives, and additional testing. However, although most experts agree that mammograms should begin for women at age 40 and continue yearly from age 40 to 55, at age 55 years old, the experts recommend having one every other year. The experts also recommend women over the age 75 should stop receiving mammograms because the benefits do not outweigh the risk. The main risk is the continued exposure to radiation. A very small percentage of women develop cancer because of the continued exposure to radiation. But there are also many positives of yearly mammograms, like finding cancer early on and being treated sooner before it can metastasize to other parts of the body, or having less aggressive treatment. Even though the recommendations are provided by experts, it is still up to each individual to decide which is best for her. She may continue screening every year after age 55 if she is at higher risk. So why is all of this related to nursing? Patients and family members ask nurses information regularly. A lot of the times, the patients see more of the nurse than they do of the doctor. Therefore, nurses should have a wide range of knowledge of medical information and questions. Some women feel more comfortable asking nurses about breast exam. Some questions a woman may ask include, should she perform a self-breast exam? At what age should she start having mammograms? What age should she stop having mammograms? Are mammograms dangerous or do they hurt? And what are all of the risks and benefits? It is very important for a nurse to be well informed and educated when it comes to mammograms and give appropriate, relevant, up-to-date information to any women who might ask these questions. And this is just a fun fact. October is Breast Cancer Awareness Month, as many of you know. And this is the Georgia Bulldogs supporting breast cancer when they played Arkansas. And the Arkansas's coach actually died of breast cancer a few years back. And these are my references.
So is this, do you think this information like is specifically used to states or certain areas of the country that might be less inclined to follow regulations or more inclined as far as, so I'm from New York. I was also diagnosed with breast cancer at the age of 40. So I'm one of the 17%. So in New York, I've never heard any doctor there say we don't recommend past 55 or whatever, or anything for that matter. And they started screening people at their age 35. So do you think it could be regional or state driven as far as that is concerned?
Yeah, I think that could definitely play a factor in their opinion.
In the different articles that you looked at, did it break down ethnicity or race or region as to
Yes.
the population that was being the information that is pertaining to the specific population?
Some of them did. I know it said that African Americans are more predominantly at risk.
You can remember sooner than the age of 40?
You can, yes, especially if you have like a family history, it's recommended that you do.
Okay. So thank you very much, but also the one free screening is free from someone that found out the hard way that multiple screenings, they charge you a lot more than that. So thank you very much. Very good. Well done. All right. And, oh, okay, so you've already stopped the screen share. Thank you. And let me see. So that means we should be here. Okay. Oh, I recognize that. Okay. And let me see if I can get the screen share to work the way it's supposed to. There we are. Share screen. And I have to go up here. Oh, there it is. That's the trick. I finally figured it out. All right, excellent. All right, you all set?
Yep.
Okay, judges, we all good? All right, and timekeeper ready to go. Thank you very much. I would like to go ahead and introduce Kathleen Dela Cruz, correct?
Yes.
Okay, and she will be presenting today, does simulation education improve the transcultural self-efficacy and cultural competence of nursing students? Thank you.
Okay. Good afternoon. My name is Kathleen, or some of you know me as Katie. I'm a nursing major, class of 2022. My presentation today will be discussing the research question, does simulation education improve the transcultural self-efficacy and cultural competence of nursing students? In the following presentation, I will define both transcultural self-efficacy and cultural competence, as well as the benefits of simulation in baccalaureate nursing education, the tools used to measure the outcome of educational interventions, and provide a brief literature review of the sources I utilized to conduct my research. So the United States is becoming increasingly diverse, and in turn, so is the patient population. Currently, the US has more foreign-born residents than any other country in the world, and this ever-changing demographic requires culturally competent nurses serving that population. A lack of a culturally competent workforce is among the leading factors that contribute to healthcare disparities in the United States. Therefore, nursing educators have been bestowed the responsibility of instilling and nurturing cultural competence among their students. This task not only requires inclusion of cultural lessons, but for faculty to assess their own cultural competence as well. According to the American Association of Colleges of Nursing, delivering culturally competent care is a fundamental expectation of the baccalaureate nursing graduate and the professional nurse. The AACN also mandates that attention to diversity must be given. This attention is required to ensure that patient-centered and high-quality care is delivered. So what is transcultural self-efficacy and cultural competence? At the root of it all, self-efficacy is a term developed by the late psychologist Alfred Bandura that is defined as the belief in one's own personal capabilities, providing confidence and motivation to succeed. Therefore, transcultural self-efficacy is the perceived competence in learning and performing transcultural nursing skills or providing nursing care to patients whose culture differs from that of the nurse. Transcultural self-efficacy is a dynamic and constantly evolving construct that with continued exposure to different cultures continues to grow and expand. A nurse must be confident with their ability to provide culturally sensitive and appropriate care when working with patients from cultures different than their own. A lack of perceived transcultural self-efficacy can cause patients with cultural differences to feel discriminated against or miscommunicated with. This can lead to issues such as incorrect diagnoses, incorrect nursing interventions, and inadequate assessments. Transcultural self-efficacy is a component of a larger construct known as cultural competence. Cultural competence is the ability to work within the client's cultural context and provide quality, patient-centered nursing care. It consists of the attitudes, knowledge, and skills needed to provide this culturally competent care. Both transcultural self-efficacy and cultural competence are lifelong developments that nurses must continue to work on throughout their careers. Culture influences pretty much every aspect of a person's life, from the clothing they wear to the language they speak to the food that they eat. It even influences their views on others, including healthcare and healthcare providers. When I mention diverse cultures, this includes, but it's not limited to, a person's ethnic origin, race, age, sex, gender identity, religious beliefs, socioeconomic status, and sexual orientation. All of these factors are indicative of a culture, and if we were to go further, which we won't, there are even subcultures within these various cultural groups. When it comes to language, culture influences not only the language a person speaks, but also their nonverbal communication as well. Certain hand gestures may be considered polite in one culture, but found offensive in another. Culture can influence a person's idea of family roles and structure. Some cultures may view males as the head of the family, while others may view females like mothers, aunts, and grandmothers as heads of the family. Some cultures, like the Amish, for instance, consider the entire community to be one large family, whether related through blood or not. Food choices are influenced by culture. Some religions do not allow consumption of certain foods or food combinations. Take the Jewish faith, for example. A kosher diet prohibits consumption of any fish with a shell and the consumption of meat and dairy together in the same meal. Some Asian and Hispanic cultures believe in drinking hot liquids during illness or refusing cold liquids when ill. Rituals surrounding death also vary by culture. Muslims, for example, have a male head of the family care for the washing and preparation of the body, and the body must be buried within a certain time frame. Even the way emotions are displayed surrounding death is different between cultures. African Americans are outward and expressive with their emotions, perhaps crying and praying loudly. Attitudes towards healthcare and healthcare providers also varies by culture. There are certain expectations within cultures on how to behave when sick. Some cultures may feel the need to be very vocal, while others try to remain stoic and not show much emotion in regards to pain. Now you can see why cultural competence is an integral part of quality nursing care. How can we care for our patients properly without knowing how they behave in certain situations and choices they may make under certain circumstances? Okay, quick history lesson. Here you can see two photographs. One on the right of nurses in a hospital utilizing what we would call today a mannequin to practice nursing skills. On the left is a photo of a doll known as the Mrs. Chase doll, a life-size doll that was used to practice skills such as turning and bathing patients and eventually to practice injections. The first real modern use of simulation dates back to 1911 in Hartford, Connecticut, when nurses at the Hartford Hospital Training School were using straw-filled dummies to practice their clinical skills. At the time, there was a well-known doll maker in Rhode Island, Martha Jenks Chase, who was contacted by the principal of the Hartford Hospital Training School. The principal requested that Mrs. Chase create a lifelike doll for the nursing students to better practice their skills. Not only was Mrs. Chase a renowned doll maker, but she was also the wife of a physician. She was able to use his medical expertise to create a lifelike doll for the school. The doll was fondly named Mrs. Chase after her creator. And a few years later, Mrs. Chase updated her doll to a new one named Arabella, who had limbs to practice injections as well as abdominal, rectal, and vaginal cavities. So as you can see, modern simulation has been an integral part of nursing education for over 100 years. And fun fact, you can still see some of the Mrs. Chase dolls in various museums around the country. And if I read correctly, the Hartford Hospital, which still exists in Connecticut, still has the original doll. So you can see it there. So simulation education, as you can now see, has long been a component of nursing education. Simulation can range from very simple methods, like using an orange to practice injections, to complex and realistic with the use of standardized patients. Simulation methods also include virtual simulations, role-playing, and use of mannequins. Simulation is a tool to augment classroom learning by providing hands-on experiences to students in a controlled, risk-free environment. It is a safe space for students to practice skills repeatedly and to make mistakes without causing harm to real-life patients. Reality-based simulated patient care experiences increase self-confidence in communications and psychomotor skills, as well as professional development. Studies have shown proven increases in self-efficacy of students who have participated in simulation scenarios. Simulation acts as a bridge between the classroom and the clinical setting. Students learn through didactic measures such as lecture, then transfer that knowledge into the simulation setting, which allows them to use their clinical and critical thinking and judgment before entering a real clinical setting. According to the International Nursing Association for Clinical Simulation and Learning and their standards committee, simulation must be purposefully designed to meet identified objectives and optimize the achievement of expected outcomes. The Healthcare Simulation Standards of Best Practice Simulation Design states that simulations must use various types of fidelity to create the required perception of realism needed for learning. They also state that a major component of simulation is the pre-briefing and debriefing stages. Pre-briefing provides students with the comfort of knowing that the simulation is meant as a learning experience in a non-judgmental setting. They are provided with materials and context needed for the simulation. Instructors are also expected to convey their expectations and desired outcomes of simulation. Debriefing provides students the chance to reflect on their experience and discuss what they believe they achieved and what they could work on. It provides instructors and simulation actors the chance to provide constructive feedback as well. So culturally centered simulation provides a deeper context for students when practicing their clinical skills. Often in healthcare education, culturally bound aspects are often included in curricula as separate studies. But this does not support integration of cultural competence. Simulation promotes curiosity and learning beyond the immediate simulation experience. Culturally centered simulation integrated into simulation education can improve the skills of healthcare students to focus more on the patient's individual needs. It can teach them to learn and utilize culturally specific and situation-specific skills involving interviewing, assessment, and providing of physical care. Simulation with a cultural focus provides nursing students with diverse encounters that they may not be guaranteed in their clinical rotations. Faculty can incorporate culturally specific scenarios into simulation to provide the knowledge and skills needed to grow cultural competence. For example, in our community health course, we had a home health simulation, where we were tasked with providing patient education to a patient of a low economic status. A standardized patient or actor was used to portray the patient. This provided us with real human interaction and emotion that made it possible for us to learn how to speak with someone who may differ from ourselves economically in a respectful way. We discussed how she would manage a healthy diet on her budget, as well as afford her life-saving medications. Culturally centered simulation promotes cultural engagement rather than cultural stigmatizations. And as mentioned before, it promotes curiosity. Students may begin to dive deeper into cultures and learn more than they are taught in the classroom. Culturally diverse simulation scenarios may incorporate values and beliefs that differ than those of the nursing student. For example, the student may not view the consumption of alcohol the way another culture does, or maybe regionality may even influence the nurse's patient care delivery. Debriefing post-simulation provides the opportunity to further discuss and learn about cultural diversity. It provides the opportunity for the student to enhance their self-awareness and even gain awareness of their hidden feelings or biases. Overall, it provides them the chance to learn how to deliver care with a non-judgmental attitude based on their own personal culture and beliefs. The evidence I researched shows that culturally specific scenarios incorporated into simulation education does in fact increase the transcultural self-efficacy and cultural competence of nursing students. So how do we know that culturally specific simulation increases the TSE and CC of nursing students? We asked them. Since both transcultural self-efficacy and cultural competence are perceived abilities, you must ask the person if they perceive themselves to have these abilities and their confidence in those abilities. Most, if not all, of the studies I researched utilized one of two validated tools, the transcultural self-efficacy tool, which I'll refer to as TSET, and the cultural competence assessment, which I'll refer to as the CCA. Both are questionnaires that were provided both before and after participating in culturally specific simulations. Results overwhelmingly showed an increase in the perceived TSE and CC of nursing students. The TSET is an 83-item tool in the form of a questionnaire that was designed specifically for undergraduate nursing students. It has 3 subscales, including cognitive, which asks questions regarding the student's cultural knowledge and the confidence of this knowledge. Practical, which asks questions regarding their confidence in situations such as interviewing, assessing, and providing patient education to cultures other than their own. And effective, which asks questions regarding their belief in their level of acceptance, value, and appreciation of cultures other than their own. The cultural competence assessment is a 44-item tool in the form of a questionnaire. This questionnaire has 2 subscales, including cultural awareness and sensitivity, which evaluated their cognitive skills in regards to cultural awareness and cultural competence behavior. According to my research, the outcome of both tools proved that the transcultural self-efficacy and cultural competence of nursing students did in fact increase following culturally focused simulations. To conduct my research, I used Piedmont University's online research databases, specifically CINAHL, ProQuest, and JSTOR. I used these, but not limited to, these search terms, including simulation, simulation education, transcultural self-efficacy, and cultural competence. The articles varied by study type, including both qualitative and quantitative, longitudinal, and systematic reviews. I ensured the validity and evidence of the articles using Johns Hopkins scale and included articles on levels 2 through 4. A major limitation of my research is the amount of studies that have been conducted focusing specifically on culturally specific simulation education. I found an overwhelmingly large amount of articles that discuss the outcomes of simulation on nursing students, but not specifically on those that focused on culture. So some common themes that I found through my research was cultural competence and awareness, the importance of both cultural competence and transcultural self-efficacy in the nursing profession, the increase in transcultural self-efficacy and cultural competence among nursing students who participated in simulation, and that transcultural self-efficacy and cultural competence are lifelong processes that aren't necessarily ever completed. So I'll finish out with some recommendations that I have after conducting my research and being an undergraduate nursing student myself. I think that measuring the transcultural self-efficacy and cultural competence of all nursing students at the start and completion of their program should be a requirement. I think it'll help guide faculty in structuring the appropriate educational interventions needed for their students and then the outcomes of those interventions. I believe schools should provide more culturally centered simulations rather than simply skill-based simulation. I also feel that the use of live actors or standardized patients provides a more realistic human interaction and emotion and is beneficial. Finally, I think faculty should assess their own cultural competence and transcultural self-efficacy. So in conclusion, my research question was supported by my research that delivering culturally competent care is a fundamental expectation of the professional nurse, and that simulation education does in fact improve cultural competence and transcultural self-efficacy of nursing students. And there is my reference list. And do we have any questions?
And we were preparing you guys for the nursing world out there, where your population is culturally diverse. But nonetheless, you know, so that was a great place to be.
Absolutely. All right, thank you.
Concluding session 4 of the symposium in 310. Thank you very much. At this time, I think everybody's pretty much wrapping up, but you might be able to catch the very end if you want to race to 312 or anything. But otherwise, thank you very much for participating today. We really appreciate all your research. It's been very interesting. Well done. And thank you very much. Have a good night. Everybody go celebrate. Very good. Thank you.
I didn't. Want to take a picture real